It's not something that I would do often, so thank you for being flexible. And for everyone else just waiting, thank you for being here and for your patience. So we're gonna be starting in about a minute, actually a few seconds as soon as we go live. Delegate Chi, if you can come up with your panel, that would be great. So good afternoon and welcome to bill hearings for the House Health and Government Operations Committee. I'm your chairman, Jocelyn Peña-Melnick, joined by my vice chair, Delegate Bonnie Collison, who's going to be here shortly. She's also in another meeting. I kindly ask for your patience if we encounter any technical or streaming issues. Please set your devices, which I'm going to do so I'm not embarrassed, to vibrate. If you have to have a conversation, please go outside. As a reminder, there's no food or drink allowed in the gallery because staff has to clean it. You will see us drink because we are here for hours and we have to stay hydrated so we don't get sick. For each bill, we're going to hear from the bill sponsor and the sponsor panel, followed by witnesses. The bill sponsor testimony here is not limited. While all witnesses have 2 minutes to provide testimony. However, don't abuse it because I'll have to tell you to wrap it up. And don't make me do that, please. A timer is displayed on the screen and a sound will play when your time has expired. Please adhere to our usual committee rules. To the committee, and you've been doing great, of one question and one answer. Sometimes I'll be a little flexible depending on the issue. And please keep your questions brief. Member of the public will be able to view the live stream of this hearing on the Maryland General Assembly website and on YouTube. Before I go to the bill order, I like to say that the way it works is we have favorable with amendment, and unfavorable. I try to be balanced, call one panel of favorable, one panel of unfavorable, just to be fair as well. So the bill hearing, the order is as follows. It is House Bill 827, Delegate Chi, and she's already up there. Thank you. House Bill 982. House Bill 755, House Bill 736, House Bill 84, and House Bill 865. Keep in mind that I may sometimes change the order if the delegate is in another room or there's a witness that we're waiting for. If you see that we get up, it's because we have bill hearings in other committees. However, we do listen and watch the proceedings since they're recorded. So, and we read everything that is submitted in our files. So Delegate Chi, will you be so kind and get started? And thank you for being with us today.
Thank you, Madam's Chair and the Vice Chair. I can see from your thorough explanation that you are really the kinder and gentler committee, even though ECM tries to claim to be. Good afternoon, my wonderful colleagues of Health and Government Operations Committee. I am Delegate Lily Chi, here to present HB 827. The bill requires the Maryland Insurance Administration to conduct a comprehensive study of professional employer organizations, commonly known as PEOs, by reviewing their offers, regulations at both federal and the state levels, and how businesses can access their services if they choose to. Specifically, the study will look into the potential impact of allowing small businesses to offer health insurance benefits to their employees through PEOs and how that might impact Maryland's market. The goal is to ensure competitiveness in our health insurance options for Maryland's small businesses for whom the most valuable asset is their people and who want to be able to offer the best health benefits to their employees wherever the plan might come from. PEOs are called professional employer organizations because they function as co-employers that offer a range of essential HR and benefit services, including payroll, health insurance, retirement savings, regulatory compliance, and more. There are currently over 500 different PEOs operating all across the country. Maryland is one of only 3 states, besides Alaska and Maine, that prohibit small businesses with fewer than 50 employees from participating in the PEO's large group health benefits if they choose to use the PEO's services. Since 96% of Maryland businesses have fewer than 50 employees, this essentially means we don't have an active PEO presence in our state. This policy stems from a desire to protect the small group market. But without credible data to support the existing policy, it's hard for us to justify and explain to our business community why they shouldn't be allowed to offer competitive benefits to their workers as they compete with larger employers to attract and retain skilled workers. With a better understanding of the impact of PEOs on the Maryland market, we can be sure that what we have is indeed the best for our small businesses and our workers, which will in turn make Maryland more competitive. I greatly appreciate the input from the Maryland Insurance Commission, especially the commissioner herself, who is going to speak in a minute. And the commission is willing and ready to conduct the study because they also want to find out the data. And I greatly appreciate the Vice Chair, Delegate Bonnie Collison, who offered valuable insights in our conversation. This bill got strong support, of course, from the business community, including the Maryland Chamber of Commerce, the Regional Manufacturing Institute, the National Federation of Independent Businesses, and the Retailers Alliance, among others. It is in the spirit of making Maryland more competitive, and by the way, today is Economic Development Day in Maryland, that I urge you a favorable report to require MIA to conduct a study and submit a report to this committee by the end of this year. Thank you, and I would like to turn to Commissioner Kathleen Brain of the Maryland Insurance Administration.
Good afternoon, Commissioner.
Good afternoon, Madam Chair and Vice Chair, members of the committee. Thank you again for the opportunity to testify today and for allowing me to do so virtually. House Bill 827, as we've heard, would require the MIA to prepare a report that addresses professional employer organizations with a specific focus on the ability of small employers who have engaged the services of a PEO to access the large group health sponsors plan sponsored by the PEO. As noted, Maryland is one of 3 states that effectively prohibit small employers from participating in a PEO-sponsored large group health plan. I won't get into the mechanics of that here, but I will also echo that this prohibition reflects longstanding concerns about what the impact of opening up that option would mean to the small group market. We have been very protective in Maryland of any leakage from participation in that market. When small group reform was initially passed about 40 years ago, it is certainly true that there were organizations that called themselves an employee leasing organization or a PEO that really were just ruses to avoid the small group mandate. But in the intervening years, PEO regulation at the state and federal level has expanded considerably, and PEOs are a tool that are used by many small and successful but small businesses to provide not only payroll and HR service, but access to health, welfare, retirement benefit plans and packages. And in Maryland, small employers can take advantage of those welfare retirement benefit plans and packages, but not the health piece of those packages. So the purpose of this study is to provide this body with a fulsome report on the PEO industry, its history, its regulation, the experience of the 47 states that permit access, and what the potential impacts on the small group market here would be as you address any legislative or policy initiatives that might come before you in the future. The MIA has the ability and the resource to prepare this report, and we're happy to provide it. So thank you, and I'm happy to take questions.
Thank you, Commissioner. We appreciate you. Mr. Sanchez?
Okay. Good afternoon, everyone. My name is Ken Sanchez, serving as the president and CEO of a manufacturing company in Sparrows Point. Our company is recognized globally for manufacturing steel abrasives and foundry sand additives. We've recently won the President's E Award for International Exporters, as well as the SBA's 2022 Maryland Small Business Exporter of the Year. I also had the honor of being awarded the World Trade Center Institute Leadership Award from Governor Moore last year. I feel I'm a good representative for Maryland small business. I'm here to ask you to equal the playing field for us and, more importantly, for our employees. As a small business, it's extremely difficult to manage all the legal and administrative issues associated with what a PEO does. This is why most of us outsource to companies like ADP, Paychex, and others that you may not have heard about. So, okay, let's talk about the healthcare. Do you know that the average small business pays 77% of all healthcare costs for our employees? I'm sure that each one of you wants good healthcare for your constituents, but these plans aren't cheap. In fact, our investment to our workforce health is substantial, averaging over $8,500 per employee. Despite the high costs, we prioritize offering quality healthcare benefits to attract and retain our talent, often providing better plans than those available through ACA. The ACA plans would be significantly more expensive for our employees if they were to obtain them independently. Small businesses make up 99.5% of all businesses in Maryland. Small businesses employ over 50% of the Maryland employees. So why does small business pay more? It's perplexing and disheartening that small businesses face greater challenges and expenses, particularly in areas where legislative support and economic policies could foster growth and stability. Not only does this make our healthcare more expensive, but it also prohibits us from getting data of the usage of the medical care of our employees. And I don't mean HIPAA information, I mean data that would help us customize our plans to provide even better healthcare for our employees. Again, large companies can do this, but Maryland won't allow PEOs to serve small businesses in this capacity. And don't we all want better healthcare for Marylanders? So we're just asking right now for this, not to change the law. This is just for the study. So please, I'd ask that you vote for this bill and let us do the study so that we can show that we can get better healthcare for Marylanders.
Thank you, and thank you for being with us today. I'm going to open it up for questions now. Are there any questions for the sponsor and our panelist? Delegate Lewis.
Thank you, Madam
You're
Chair.
welcome.
Thank you, Delegate Chief, for bringing this really interesting bill, and thanks to your panelists, Commissioner, Mr. Sanchez. I share your concerns about expanding access to affordable health insurance for small businesses. And there have been a couple of bills that have moved around over the last few years trying to do that. Your idea is new to me, so it's interesting. I'm wondering if you have information about other states where those businesses offer health plans, what they look like. Do they follow ACA guidelines? What sort of price range is offered and the benefits? I'd just love to learn more about what we might be walking into after the study and all that.
Yeah, it's an excellent question, and it's part of the impetus for this request to conduct a more comprehensive study. While every state is different in who they allow to operate in their state to offer these benefits to businesses. So far, from everyone I've spoken with, from NAPIO, from Commissioner and other business, I don't think we have clear data to say that the states, which is the vast majority of the 50 states, right, 47 states, in those states that there is such a disruption to the small group market. So we just want to make sure that in the context of ACA and our desire to advance ACA and make sure we have a healthy pool and lower the premium for everyone, that in that context, we can have a credible assessment of what makes sense, right? So yeah, and you can have the commissioner chime in, but that's my understanding. That's why we want to find out.
My pleasure. Next, we have Delegate Hill.
Thank you, Madam Chair. And thank
You're
you,
welcome.
Delegate Chief, for this, I think, really good bill. I think the question is for the Commissioner. I'm curious about the advantages and disadvantages of participating in the small group market, which these businesses with less than 50 employees are, versus when they pool together, right? So they're now large group. And I think what you're saying is we don't allow them to become large groups. So ADP or someone else, as Mr. Sanchez testified, can group them together and do their HR together. They can do other kind of benefits together. But when it comes to healthcare, we're telling them you have to act like the individual small business as you are and you can't purchase that together, what are the advantages of participating in a large group market versus the small group market?
Right. So what happens is that the PEO is by law becomes a co-employer. So as a co-employer of the individuals for all of their clients, they sponsor a fully ACA compliant, fully insured large group plan, which are, plans that have to meet all of the ACA requirements that apply to large group. Their benefit plan, it kind of looks like a Fortune 50 company, right? They're usually very rich in benefits, much lower deductibles, much lower copays. And in addition to that, oftentimes the premiums are lower, but the employer is paying the bulk of that in any event for individuals. I would also just note that in order to have access to the PEO's large group plan, you have to engage the PEO, right? So it's not like an association plan, you just join up and then you can jump into that, right? The participation nationally in PEOs by small employers fluctuates. These are numbers that we have to update that would be part of this report, but they kind of hover between like 9 and 10%, because not every small business can afford to hire a PEO or to utilize their services and therefore have access to this co-employer arrangement to that large group plan. I hope that answered your question.
Any other questions? Delegate Kipke.
Thank you, Madam Chairman. Ms. Bahrain, we ask the MIA and other agencies a lot for studies and reports, and sometimes we don't get them until much later than requested. And since this obviously would pertain to possible legislation next year, I'm just curious, is this enough time for the MIA to do the work that needs to be done to provide the legislature with this report?
I think so. I think the MIA tries to pride itself on pretty much always getting them in on time. I think since I've been here, we may have missed one by 15 days this past year. But I did sit down with the sponsor when she asked us about this, and I did sit down with my team. Probably 75% of this report is really pulling together information from other sources. I wish that there was some deep data source that we could sit down and give you a full actuarial study on what this would mean. We've made it clear to the sponsor we can't do that because that data just isn't collected. But what we can do is do a lot of comparative analysis between, the 47 states that allow this and what impact, if any, that seems to have had on their market as opposed to the operation of our small group market. There was a study that was done by my colleagues in Massachusetts, which has a combined market that will leverage some of that information. But the short answer is yes, we have enough time to do this.
Okay.
You're welcome. I don't see any other questions. Thank you so much for being with us. We really appreciate it. And this bill will be assigned to subcommittee. Make sure to come. Okay. This actually concludes the bill hearing on House Bill 827. Next, we have House Bill 982, Delegate Kipke, genetic testing prohibitions on disability, life and long-term care insurance, Genetic Testing Protection Act of 2024. Delegate Kipke, can you please bring your panel?
Thank you, Madam Chairman.
I think I have Jenna Suplet, Coldip Dave, Leah Peabody, Vincy Gill, and Brian Schaefer. You can get started. Thank you so much.
Thank you so much. House Bill 982 is a reintroduction from a bill from last year that would, if enacted, prohibit individuals from being discriminated against should they take a genetic test, not have an illness, but take a genetic test. We've talked a lot over the years about those tests that are done on newborn screenings. That's a genetic test. And there could be new breakthrough tests that get added to that help identify and screen individuals. these genetic tests are increasing as technology expands. And can you imagine being perfectly healthy and taking some genetic test that tells you that you might have a marker for something? Doesn't mean you're ever going to get it. But then a life insurance company, a disability insurance company, or long-term care insurance company could use that to block you from access to their products. So this bill would simply protect those individuals from being impacted just based on the fact that they have a genetic test. This isn't breakthrough or, wild and radical policy. It's been enacted in other parts of the country. We talked about Florida last year, where that remains a policy in their state. And I want to thank the committee for their time and attention to this issue, and I'm going to turn it over to my panel. Thank you.
All right. Who will be next?
I can go next. Good afternoon, Chairwoman Peña-Melnick, Vice Chair Cullison, and members of the HGO Committee. Thank you for the opportunity to provide testimony in support of House Bill 982. My name is Jenna Sublett. I work with Cornerstone Government Affairs, and I'm here on behalf of our client, the ALS Association. And thank you to our incredible sponsor, Delegate Kipke. I want to take a moment to distinguish the difference between genetic testing and a diagnosis. A genetic test means a lab test of a human chromosomes, genes, or gene products that's used to identify the presence or absence of alterations in genetic material that are associated with a disease or illness. A diagnosis identifies an individual's confirmation of a disease or illness. A genetic marker does not always progress to a disease. Regardless of the outcome, individuals have the right to know about their genes, learn from them, and they should not be treated differently due to their genetics. For those concerned that this could lead to increased rates for policyholders, we have not seen any data to support that. Over the interim, we had a 50-state outreach from the MIA to see if anyone in the insurance administration could send us data to show that their market had been impacted by having a protection in place. Not one state sent us information or data to support that. Maryland is not the first state to introduce this legislation. Florida has had a law in place since 2020. There's also 13 other states that have patchwork protections, including Maryland, who passed this law in 2008, specific to long-term care insurance. As of right now, there are 5 other states that have introduced bills just this year similar to ours. And specifically in South Carolina, their bill is also moving. You might hear that this has never been done, but it's not a new concept. And ALS is not the only one fighting for this. Please refer to my written testimony, which shows the support of our coalition of organizations. Thank you for your time, and we would request a favorable report for House Bill 982.
Thank you for being with us today. Who will be next, please?
I will be next. Good afternoon, Chairwoman Peña-Melnick, Vice Chair Cullison, and members of the HGO Committee. Thank you for the chance to testify in support of House Bill 982. My name is Lindsay Gill, and I am the Managing Director of Advocacy at the ALS Association serving Maryland. Thank you, Delegate Kipke, for introducing this legislation. I would first like to address that it is not our intention for this legislation to negatively impact the life insurance market. We want people to get genetic testing and life insurance, but affordably. Our bill does not prevent insurers from accessing an individual's medical record as part of an application exam. In some cases, genetic test results can prevent a patient from getting a life insurance policy. There are also times that patients are offered coverage at an extremely high premium. That is what our bill addresses, avoiding discrimination as it concerns issuance and price protection. An important distinction is that a genetic test indicates potential health risks. It is not a diagnostic exam and should not be treated as such by life insurers. For well over 125 years, life insurers and applicants did not have genetic testing information, and their business has managed to flourish. Life insurers claim that they will never require a patient to receive a genetic test to obtain a policy, but we don't have any law in place to support that. Medical records for the purpose of medical underwriting have been used for decades. It's unfair for insurers to base issuance and pricing decisions on private and personal genetic information, and it is completely unnecessary for the sustainability of their business. Genetic testing and genetic counseling are crucial to family members that have ALS, as it helps to inform prevention, future treatment options, innovative breakthroughs for this devastating disease, and important life decisions. But this bill not only impacts those living with ALS, it impacts all Marylanders living with a genetic condition. Think of it this way. M&T Bank Stadium holds 71,000 people. The number of Marylanders living with a genetic condition is the equivalent of 2 M&T Bank stadiums. Many of these folks are already seeking and securing life policies just without information that would help them plan for their health risks, if not for the fear of denial or high costs across insurance markets. For these reasons, I respectfully request your support for the Genetic Testing Protection Act.
And thank you for your testimony today. Next, please.
Hi, good afternoon. My name is Dr. Kuldip Dave. I'm a neuroscientist and I'm Senior Vice President of Research at the ALS Association. I appreciate the opportunity to speak to you today in support of House Bill 982, but more importantly, in support of more than 200 families with ALS we currently serve in the state of Maryland, and over 30,000 people living with ALS in our country today. ALS is a devastating neurodegenerative disease that progressively robs people of their ability to move, speak, eat, and eventually breathe. Once this deterioration begins, there's no way to stop it, meaning that most people only live for about 2 to 5 years after being diagnosed. The discovery of more than 40 genes, I'll repeat that, more than 40 genes linked to ALS has opened the door to an era of unprecedented change in ALS care and research. The first genetically targeted treatment for ALS was approved just last year. And at least 10 other genetically targeted therapies are being tested in clinical trials, with almost a dozen more being tested preclinically. One such study is currently underway at Johns Hopkins, and that even goes further. It is testing therapy to prevent ALS from developing in the first place for people that have the gene but don't have the disease yet. Imagine what it would mean if we could stop ALS before it starts. The lives and futures it would save, the financial, social, and economic costs that would never be incurred. A major barrier to making this a reality is that few people with ALS and their family members know their genetic status. Fear of their genetic information being used against them is the reason why. Thus, the threat of genetic discrimination creates a serious dilemma for Marylanders. Just one last sentence. Risk their physical health because they don't know their genetic status, or risk their financial health because they do. House Bill 982 will remove that threat, improving the health of Marylanders and accelerate the massively important science done in this area. I urge you to support it. Thank you for your time and consideration.
Thank you for your testimony.
Hi, my name is Lisa Peabody and I live in Bethesda, Maryland, so I'm a constituent, but I'm also the advocacy manager for FORCE. FORCE and I strongly support HB 982. The current system of using genetic information to determine premiums and eligibility for long-term care and disability insurance unfairly discriminates against people with genetic predispositions to cancer. FORCE is a national nonprofit also serving Marylanders who face hereditary cancers. Most of our community carry an inherited genetic mutation that increases their cancer risk. You may have heard of BRCA1 or 2. However, there are over 40 genetic mutations putting people at higher risk of several cancers. Those include breast, colon, prostate, endometrial, gastric, and pancreatic. I have 2 points to make today. Number one is that not all genetic mutations are the same. Individuals with an inherited cancer mutation can take proactive measures to dramatically reduce their cancer risk. Individuals can begin screening at younger ages and at more frequent intervals to identify and diagnose cancer at an earlier stage. Some patients even choose risk-reducing surgery like removal of ovaries and mastectomies to lower their risk. Individuals with Lynch syndrome, another type of genetic mutation, can have up to an 80% chance of being diagnosed with colorectal cancer. However, abnormalities or polyps can be removed immediately during a colonoscopy, and those patients undergo more frequent colonoscopies at younger ages. It's not fair or accurate to put all these people with genetic mutations into the same high-risk bucket. Just because you have a mutation does not mean you will get cancer. Number two, Fear of discrimination. This is something we've been hearing from LS as well. Some people refuse to get genetic testing, fearing that identifying a mutation will impact their ability to get insurance. This means they don't have the extra screenings or the surgery. And if their doctor recommends intervention because of their family history of cancer, they don't have the proper documentation in their medical records to get coverage for these screenings. So they just don't screen. Please support HB 982 and stop the discrimination of people with an inherited genetic cancer mutation.
Thank you. There's also the gentleman, Mr. Brian Schaefer. Thank you. Good afternoon, sir.
Good afternoon. My name is Brian Schaefer, and I live in Bel Air, Maryland. ALS has robbed me of 4 members of my family: my grandmother, my aunt, my sister, and my father. In 2 of the 4 cases, I watched firsthand them little by little lose all of their physical abilities until they ultimately lost their lives. I watched my dad trying to provide for his family, trying to continue working for BG&E, even when he could barely move his arms to lift things. I watched him almost choke to death in our kitchen, at our kitchen table, because near the end of his life, he was having trouble swallowing. I remember running to our neighbor's house to get her because she was a nurse, and thankfully she was able to save his life. I watched my sister, who was a teacher, using a microphone in her classroom because she could barely speak and wanted to be able to continue teaching as long as possible. As things progressed, I eventually had to feed her because she was unable to do that anymore, something that no older brother should ever have to go through for his older sister. ALS is a horrific, cruel, painful way to die that I would not wish on my worst enemy. Now, as a proud father of 7 wonderful children, I am faced with something even worse than that I went through with my dad and my sister. And that is the prospect that my children will not get the genetic testing available that can tell them if they have any of the genes that can lead to ALS. Right now, we are fearful that we will not be able to get life insurance coverage in the future should it be discovered that they have the genes that lead to ALS. My children are young. Getting a life insurance policy right now is not on their radar, but potentially getting a genetic test is. While there's no cure for ALS, knowing they have the gene that can cause it would allow my children to be able to watch for any symptoms of the disease. And if they were ever to have any symptoms of ALS, they could immediately start medical treatments that could prolong their life. And I just want to close by saying, just because someone tests that they have any of the genes that can lead to ALS doesn't mean they will get the disease. There's no valid statistical fact-based reason for insurance companies to discriminate against someone who gets the testing done and tests positive. Only fear tactics. I ask you to please pass this bill. It's hard enough to get tested knowing that you could have one of the ALS genes. Don't make it any harder for anyone because they live in fear for not being able to get life insurance as a result of being tested. I ask you to please support this bill for my children and their future.
Mr. Schaefer, I want to, on behalf of the committee, just say thank you for sharing your personal story. I'm so sorry that your family has to deal with so much, illness.
Thank you for allowing me to testify.
You're welcome. May we, actually, I'm going to open it up for questions now. Are there any questions for the delegate and his panel? Vice Chair Collison?
Thank you, Madam Chair, and thank you all for being here and telling your stories. So you all understand that life insurance always pays out, right? When you buy life insurance, it pays out. It's different from health insurance because health insurance only pays out if you need it, but life insurance always pays out. So whatever your policy says, that's what your family is going to get upon your passing. So when I bought life insurance, which I didn't do until I was 60, I was asked, have I ever smoked? who in my family had a heart attack, who in my family had cancer. All of those things went into underwriting the policy for me. And my BMI also had a significant effect on my ability to buy the policy I wanted. If just because my mother and father had heart attacks, I may not have I hope, and I'm trying to do the things that help with that. I may not have a heart attack. I have relatives who had cancer. That was considered in the underwriting. I hopefully will never have cancer. But that's all because the life insurance policy is considering those things because they know that at the end, they are going to have to pay this out. So how is that different from genetic testing, knowing that life insurance policies have to be responsible in how they underwrite potential clients?
Who's the best person to answer that?
I'll answer that.
Thank you.
We completely understand, and our intention of this legislation is not to hide any family medical history, the medical history that is provided, all of the data points that you provided, Vice Chair Cullison. We completely understand that. Our intention is those that have a genetic condition, it should not be used against them, and they have life insurers have not had this data for some time, but now they do. And just because someone has a gene for a condition, we don't believe that it should count against them.
Sure.
One quick follow-up. But would you agree that if I took genetic testing and saw that I had a marker, that I would, if I hadn't bought life insurance already, I would be running out to buy it? I mean, and you're right, I might never get that disease that I have that marker for, but the motivation to go out and buy a policy as soon as I see the potential is going to be very strong. Would you agree?
Well, I understand what you're saying, Chairwoman. The real life doesn't work that way. Think of a sort of person who just found out that someone in their family has ALS, and they're processing that emotionally. They're processing the pain and the suffering of knowing that someone in your family has ALS, and maybe finding out that it's because of a particular gene that they have. And now having to think through, oh my God, do I have that gene? Or did I pass it down to my kids? In that emotional whirlwind of the pain of your family member or yourself, or you passing it down to your kids, you're not generally thinking of, okay, let me go grab a life insurance policy right away. It's just not something that happens in cadence in that way in real life. And so I understand what you're saying, but I think in reality, people are not thinking that way, right? I got my life insurance when I was 40. I didn't think about life insurance before that. But if my mom or dad had a gene for cancer and I was thinking about it when I was 20, I don't know if at 20 I would have thought of getting life insurance. So I understand what you're saying. I just don't think emotionally people would be there. I know you wanted to add something.
We're only allowed one person to answer.
Okay.
Someone else can ask for a follow-up. I have Delegate Woods, followed by Delegate Bagno.
Thank you, Madam Chair. So actually, Madam Chair Collison, Vice Chair, you kind of put something in my mind that's very interesting that I would like to ask about. And you all, I may be outdated in my question, but I was actually adopted. And my parents' rights were terminated. And so as I grow up in life, as I grew up, I would always be asked about my family history, and I don't know it. I don't know it at all. And so at an early age, early young adult age, I was actually placed in what they call, and you may know what I'm talking about, a high-risk category for everything, simply because I have no knowledge of my family history. How would this be impacted for something like that, for a person who's trying to find out? You understand what I'm saying? And I guess it's because what I'm hearing is it's almost like punitive, needless to say, when you find out this kind of, but how does that relevancy fall into play?
Who's the best person to answer?
Okay.
And Ms. Peabody, you get an opportunity to add a little more to what you have to say.
In terms of your question and then connecting also to your question, both delegates, thank you for asking. So the insurers have had access to all of your medical work, like you've discussed, Representative Cullison, and you're in this high risk category because they don't have that information. And that is that's the business model. And I appreciate you sharing that is the business model and that there's always a payoff. In the case of this genetic material, people are now fearful to get the test, and it is prohibiting what you were talking about, research for cancer patients. If you have a genetic marker, there's a particular drug, a PARP inhibitor, that would be great for you, and they know genetically you're going to respond well. So it is preventing people from getting the access to the information they need to better take care of themselves. That is the difference. I can still take care of myself because I have a family history of obesity or heart disease. But this particular piece is dire because it guides treatment and research. It is a new piece of information that's guiding research and information and treatment.
We have Delegate Woods. You okay?
Because I still have some questions. I don't know if
I'm not sure in terms of where you would fall in the risk of insurance. And I think that might be better for the next panel who's going to come up and talk specifically about that. But in terms of your genetic information, the same thing would happen to you if your doctor was concerned because of I don't usually when we think about genetic, for at least for cancer, when we think about genetic testing, we do look at family history. And I'm not a geneticist, so there might be more outside of that a geneticist might look at to say whether you should have genetic testing for particular diseases, because that isn't my expertise. So it's something that you would have to explore with your doctor.
And Delegate Woods, I think you can ask the question of the League of Life. When they come up, the League of Life, you can ask them. Mr. Chantilano, she's right there taking notes. He's getting ready. Delegate Bagno.
Thank you, Madam Chair, and thank you for this bill. So I'm actually on the NIH website, and this is apparently something that NIH has been reckoning with since at least 2011, because I have a guidance document. And it says the American Medical Association Code of Medical Ethics states that it may be necessary for physicians to maintain separate records for genetic testing results to ensure that the results are not sent to health insurance companies. Physicians who withhold results should inform insurance companies that when medical records are sent, genetic testing results are not included. Obviously, this is patient-centered, and it's a guidance document for physicians as they're making these decisions. So my question, and I think it's to the good delegate, is there anything in this bill that would prohibit use of family medical records exclusive of genetic testing? In other words, this doesn't change current practice. It just puts guardrails around genetic testing. Is
Yeah,
that
I think that's right. When I looked at this bill initially, some of the concerns that have been raised, I thought about those, but the practical experience is the worry does not bear that out. An individual who's single without kids is less likely to have life insurance than someone who's 40 with kids. I just increased my life insurance quite a bit with the addition of our new baby. So I think it has a lot more to do with your own individual experience, not somebody seeking to win the lottery. There's no lottery to be won should you end up ill at an early age. So the practical experience where places have enacted this policy has not brought out our worst fears. In fact, the market is stable as far as we can tell. There was an effort by the insurance lobby to repeal the law in Florida, which failed, and the sky hasn't fallen.
You're welcome. I have Delegate Hutchinson followed by Hill, followed by Johnson.
Thank you, Madam Chair. I guess really a point of clarification as I've been listening to you. I'm not sure who's the best for this, but in really going back to Delegate Collison's questioning about the pre-existing conditions. So if you're identified with a particular marker, are you saying that you're outright denied every time, or is this really just a factor that could determine the rate? And is there a history where there is, if it's all included in, is there really a history where individuals are outright denied, or is it just a matter of rate calculation?
I'm happy to answer that question. Thank you. Thank you for that question, Delegate. Both. So we have heard from our patient population, from the multiple patient populations that have supported this legislation. It is both either hearing outright denials because of their genetic information and their results, or just sky high premiums that are simply unattainable. The goal of this legislation is to address both. So there is issuance and protections for pricing when it comes to trying to achieve a policy. Like I said, we want people to get genetic testing, and we also want people to receive life insurance. Both are critical for our patient population. And we have people coming to the ALS Association seeking guidance on how to navigate this reality for them that Dr. Koldeb-Dave mentioned, in just grappling with the reality that a family member has been diagnosed and what do I do next? We are hearing from multiple neurologists in the field that are saying, if you have a family member that has received a diagnosis, we want to start getting genetic information from multiple family members so we can, enroll potentially family members in clinical trials. We are seeing gene therapies coming to the market specifically targeting genes for the disease, so people do not even start the onset of it. So the answer to your question is both. We've seen people being denied outright and very high premiums.
Delegate Hill, followed by Johnson.
Thank you, Madam Chair, and thank you, Delegate Kipke, for bringing this bill back. I think I understand the goal of freezing the information exactly where we are. The markets have worked, folks are covered, et cetera. And to say that any additional information we can get in the future should not be used. But genetic tests can go both ways. So let's say I have a family history of breast cancer, and I get genetically tested. And whether it's BRCA1, 2, or whatever, we come up with some test at some point that says your risk of getting breast cancer is close to 0. Not because of an absence of a gene, but you actually have a gene that protects you against breast cancer. And theoretically, I could go to an insurer and say, I know what my family history says, but this genetic test says that I'm at an extremely low risk because I've got the protective protein that will prevent this from happening. Therefore, I want to be moved out of the higher risk because of the family history, and I want to be covered at a lower risk because the genetic test shows you that I'm protected. So would you also say that information should not be used and it's only your history that we should be able to take into consideration, not the wholeness of the information?
Delegate, that's a really good question. It's what we call protective genes. And so there is a lot of research going on, we all worry about what genes increase your risk of a disease, but there might be genes that protect you. In fact, just to answer your question, there's a huge number of people who are over 90 and 100 years old living in an area of Italy, and people are trying to understand, they're living without heart disease, they're living up, over 100. What is it, that's protecting them? Is it diet, olive oil, whatever, or is it a protective gene that's helping them, live longer, live better? That protective gene idea has not been realized yet. there isn't a protective gene that you can point to that says this protects you against Alzheimer's or Parkinson's or ALS. It may happen in the future, and I think that is something that we may have to cross the bridge if and when that happens. It would be great if that, if we could find that gene, a protective gene like that. So you're making a really good point. It's just that we're not there yet. The research, where the research is right now, is that we have 40 genes, at least for ALS, that are high risk genes. And just like long answer, but just like you go to a doctor and get your cholesterol tested, and the doctor says, you know what, your cholesterol's high. Let's do some prevention stuff so that you don't get heart disease. You eat less Taco Bell, or, or exercise more, or take cholesterol reducing medication. In the same way, if someone knows their genetic status, there are things that they could do to prevent ALS or prevent Alzheimer's. We know that being in military increases your risk of having ALS by twofold. We know that playing in National Football League increases your risk of having ALS by sixfold. So maybe if you have a genetic mutation for ALS, maybe you don't play for the National Football League, or maybe you don't serve in the military, or maybe you don't do things that you may have a high chance of getting head trauma. And that's what we're talking about in this bill.
Sure. So exactly to that point, right? So what you're saying is that not only do you not want it to be used against you, you don't want that information for a patient to have the right, or a client to have the right to ask an insurer to lower their risk because they're doing the preventive thing. So I've BRCA2, I've had the oophorectomy, I've had the mastectomy so that I don't go on to get the cancer. And this bill would say that they can't take that into account and say you're now lower risk because you got information and you took preventative steps. We're going to continue to rate you as a high-risk patient, even though the breasts are gone and the ovaries are gone. That's what this bill would also do, correct?
I don't know why I love it. I'm sorry. So again, they're just going to look at your medical history and they're going to say, oh, this woman, because we provide medical history to the life insurers. This woman has no ovaries. She has no breasts. In general, whether we can see her, her genetic mutation, she's at lower risk for these. And she's also I can't tell for sure, possibly African-American. So she's still going to be at high risk because she's got African-American, so it isn't using your genetic mutation, but it's still having them access to everything they need to make an informed decision. So they might lower yours because you've gotten rid of those and you're an African-American at high risk, but you got rid of those two body parts. So it does work for you in your medical record. We're just trying to keep this genetic piece out of it. And, it's anecdotal whether people say they're disqualified or their premiums were raised. I mean, we recommend everyone go to a genetic counselor before they have the testing. And the reason we recommend them is because at the genetic counseling, the very first thing they say is make sure you get your life, long-term disability, and long-term care insurance before you test. So it's already known across all these genetic counselors who are guiding people with their genetic testing to make sure those are in place because of the discrimination. So although I can't collect how many people, it's anecdotal, but it's part of the practice of counseling a person about their genetic information.
Delegate Johnson.
Thank you, Madam Chair.
You're welcome.
And thank you for bringing the bill and panel for giving us the information. So from what I've heard so far, I'm going to kind of use the flip side of the question that Delegate Collison asked. So basically, you want folks to get genetic testing to be treated the same as people that they just asked the questions. And you don't want to be discriminated against, especially when it comes to cancellation and refusal to renew. Is that basically what this bill is saying?
So, yeah, I'm hoping I'm understanding your question correctly. This bill says that if you get a genetic test, then it can't be used towards you. Your medical records are still present. It's not to hide anything. It's not to say that we can't use your family history or anything like that. I'm not sure, maybe if you could repeat your question, maybe if I'm not answering it correctly.
To get the genetic test, they want to be treated the same as the folks that they ask the questions about your family history, your medical history. No more harsh or no more severe, no higher premiums than people that they would just normally ask questions to make sure that it's fair and equal.
Sure. Yes, I think I'm understanding it correctly now. So yes, the folks that receive genetic testing want to be treated as equally as those that have not received genetic testing and do not know their gene status at this point. You're correct.
Thanks.
You're welcome. Any other questions? Seeing none, thank you so much.
Thank you.
For being patient as we ask the questions, okay? We are now going to go to an unfavorable panel. And we have the League of Life, Matthew Santillano. We have ACLI, Vincent Ryan, and Dr. Deborah Vandomelian. Hope I pronounced it correctly, from Guardian Life Insurance Company.
Good afternoon, Madam Chair, members of the committee. My name is Matt Celentano, here today on behalf of the League of Life and Health Insurers in opposition to House Bill 982. We want to start by saying that ALS is truly awful, obviously, and we're all hope for a cure. And the stories that we heard prior are heartbreaking. But we need to relay that life insurance is fundamentally different than health insurance. Life insurers get one bite at the apple. They build a rate that's made specifically to you. The policy can last decades, and not a single life insurer requires a genetic test. Nobody requires a genetic test. There is no raising of rates like in health insurance. When we hear about rate review, and this committee gets a briefing every year on the health insurance rates. It's critical we get it right because the policy lasts for your entire life. This is a voluntary product, and it can never, ever, ever be canceled. This bill has a chance to really upset the marketplace. And while we're sympathetic with the proponents, there are very serious consequences to passing this bill. Life insurers just want to make sure that the majority of Marylanders that buy their life insurance products, many of whom use life insurance as their sole source of retirement, can continue to do so at an affordable price. I've asked a few experts to join me. I think some of the questions we heard have been really, really interesting, and I want to make sure that you have the best experts here to answer those questions. So I brought a couple of people with me. To my right is Vince Ryan, who is a risk classification expert at the American Council of Life Insurers. And to his right is Dr. Deb, who is a company medical director, who is an expert on this subject and walk you through any of your questions. I ask you for an unfavorable report, and I request that you look in your bill file to see a letter from the Maryland Insurance Administration that clearly states that this bill is highly problematic. Thank you for the opportunity.
Who's next?
Thank you, Madam Chair, Madam Vice Chair, members of the committee. Vince Ryan appearing on behalf of the American Council of Life Insurers. To echo Matt's comments, we do have concerns about the bill. We are asking for an unfavorable report. Just by way of background, since 2019, there have been over 30 bills introduced related to genetic testing and life insurance. Of those bills, no state has enacted an outright prohibition on life insurers' ability to consider genetic test results and information in underwriting. If enacted, House Bill 982 would be the first in the country to deny life insurers access to test information that may be predictive of risk. As has been stated, unlike health insurance, life insurers have only one opportunity to evaluate a person's risk before issuing a policy that will remain in place for a consumer's lifetime. We're in the business of forecasting risk 30, 40, 50 plus years out. Once that policy is in place, we cannot cancel or adjust premiums because of changes in a person's health or subsequent test results. This is why it is crucial to have access to a complete and accurate medical record. We also don't view genetic test results as exceptional and separate and apart from the routine medical file. And in fact, they are weighed against the full scale of factors contained in the medical profile of each individual applicant. Our members take a holistic approach. We consider a wide range of factors, including steps a person might be taking to manage their health risks. In fact, in many cases, consideration of a genetic test or genetic information contained in an applicant's record can be a benefit. Contrary to what has been said here today, life insurance availability is very competitive and accessible in Maryland. Recent studies have even shown that 93% of all life, long-term care, and disability applicants are approved on their first application for coverage and receive preferred rates. Today, our ask is simple: to know what the applicant knows and what is in their medical record at the time of application. Thank you for your time, and I'm available to answer questions.
Thank you for being here today. Next, please.
Thank you, Madam Chair and committee members, for allowing me here today. My name is Dr. Deborah Van Domelen. I have been a life insurance medical director for 15 years. My training is in family medicine with degrees in public health and genetics. I am here on behalf of the American Council of Life Insurers. While this bill obviously has the best of intentions, I will describe the potential unintended consequences that could do more harm than it helps. Underwriting has actually lowered the cost of coverage for consumers and offered protection to families who could otherwise not afford it. For this reason, states will require insurers to group applicants based upon similar life expectancy, or what we call risk pools. The math simply falls apart when individuals with the highest risk of premature death are forced into the lowest risk pools. The Maryland genetics bill would be the most restrictive in the country, if not the world. No other law has disallowed the use of family history, and for good reason. Being the only state on the books to have this on the books would make Maryland a target for what we call insurance tourism, where members of groups like the ALS Association might come to Maryland to purchase insurance because they would be at a lower price than what they could get at home. That leaves Marylanders to subsidize not only people in their own state, but potentially nationwide for being put into the wrong risk pool. There are other alternatives for people who have inherited conditions. For instance, just like health insurance, there are life insurance products that offer availability with minimal to no underwriting. For instance, group coverage, often as an example, provided by employers, or guaranteed issue. The codifying of anti-selection into the individual life insurance market by this bill sets a separate status for a subset of consumers. That expense then could hurt the discretionary income of the others. So as there's rising costs for food, housing, gas, it could also cause the rise for health or life insurance. And that is why I don't think this bill is good for most Marylanders.
Thank you. Thank you for your testimony. Are there any questions for this panel? I see Delegate Hill, followed by Vice Chair Collison, followed by Delegate Wood.
Thank you, Madam Chair, and thank you all. Really, two things. I heard you say, Doctor, that this bill would disallow family history, and I'm not seeing that in there. And what I think this bill does, it says it doesn't take us backwards. It simply says the status quo is good enough. You've had information to rate on, and you don't need additional information about genetics to come up with those ratings that have worked so well. I think so. I'm curious, about where you say it disallows family history. And then I'm wondering if the compromise might be that, as you point out, Mr. Chiantano, nobody is requiring genetic testing. Maybe if this can't go forward in the way it is, that the bill should say that we prohibit ever an insurer from requiring a genetic test to be carried out. So that if the people have it and they can access it through medical history, they can maybe see it, but you all, I mean, again, the status quo is the status quo. You're not requiring it now. Maybe you don't get to require it in the future. And you know, so it's really two parts. Where does it say it disallows family history to be considered? And
yeah, I think there are a number of questions in there, and I'll try to make sure that I hit all the points of it.
There are like 5 questions in there?
Yeah. So first of all, the issue of family history, there is specific language where it says we cannot consider inherited characteristics, which in our view puts family history at risk. Inherited characteristics are cancers, are heart disease. So it may not say family history specifically, but that is a concern that we would have. Family member inherited characteristics. I thought that's under the definition of genetic information, not necessarily genetic testing. Okay. So that's one of our main concerns that way. Trying to remember some of the other specific questions. I think there's also a concern you mentioned as far as requiring a test. First of all, as we've said, we don't do that now. And as I've looked at where existing laws exist related to genetic testing, I'm trying to remember, my memory isn't perfect, but I thought Maryland may already have a bill that does that, that says no insurer can demand or perform, it's probably perform a genetic test. But I don't know that at this point there is a concern for us wanting to perform genetic tests ourselves, because that does require, we've talked about the importance of genetic counseling and what goes along with a genetic test. And that obviously is in the best hands of the genetic counselors rather than us being the ones doing the testing.
I have Vice Chair Collison, followed by Delegate Woods, excuse me.
Thank you, Madam Chair, and thank you for being here. I heard you say that no other state has done this, but I'm looking at the Florida statute. And the Florida statute is pretty explicit. I think our bill is pretty much the same. And I believe the Florida statute went into effect in 2020. So there's 3 years of data. Now, I also heard the proponents say they asked Florida for their data, but didn't get it. And it's my understanding, at least from Dr. Google, that Florida is the only state that has only done this. I know it's being considered in a number of different states, but but it hasn't passed anywhere except in Florida. So my question is, can you tell us what happened in Florida or what's happening in Florida?
Sure. I would like to start by saying Florida is still a little bit different than this bill, I think in 2 ways. We can agree to disagree or look a little bit deeper to see if family history is included here. Our concern is family history is included in the restrictions here as opposed to it not being in Florida. The other piece for Florida is it did allow the use of genetic testing information when it was for a diagnosis and being given a diagnosis. And so I feel that is slightly different between the 2 places. As far as concerns of discussion of genetic tourism and how that could have affected, one of the main concerns related to Florida, we had a pandemic and there wasn't a lot of moving around. So that of that 3 years, we feel that it was unusual circumstances that didn't give us a good perspective on what the future holds. The other thing is the very big difference between health insurance and life insurance. So health insurers, they have constant claims, they have constant information coming in. So they very quickly get a feedback loop on whether their pricing is going to be in trouble or not. As pointed out by you before, we only get direct information when somebody makes a death claim. Death claims take a long time, many years to come in, and we like to collect information over those years. We don't want to immediately start hurting the consumer, and so we're going to be watching for an increased number of death claims. But the person who comes in under that bill to buy insurance, even if it's a person who may be eventually getting ALS, there's probably a 5-year window at least before that death claim is going to come in. So it's certainly too early. And our concern is by the time we have enough years to collect enough data, it's going to be too late for us to reverse course as it applies to paying out for the lifetime of every single policy that we have in place.
You're welcome. I have Delegate Woods.
Thank you,
You're
Madam
welcome.
Chair. Madam Chair, I kind of have two kind of questions
It's
directly.
okay,
Is
go
that
ahead.
okay?
You know,
So-
you usually don't ask so many questions, so you could take
know.
two of Delegate Hill for.
I am feeling empowered today.
Yeah.
So here's my question. I go back to the initial question that I asked, because this is very interesting to me for a number of reasons. But one of the reasons is I said that, you know, this was probably obsolete for me as a child, and that I was literally automatically characterized, not as a child, but when I became an adolescent, as being put in a at-risk group because I was adopted. My two questions are this: at what age range would you be able to find this characteristic, number one? And number two, because I know that today, very different, and I'm not going to tell you how many years old I am, but very different from when I came up. Today, parents are getting that. They're asking that information in that adoption process. And so how is that impacted for you? You know, not every parent's going to ask, needless to say, and not every parent's going to, you know, be privy enough to know to get asked for stuff like genetic testing. But how does that impact it for someone who is going through that adoption process? And then is there a certain age that you say, because I know everything you can't tell at birth, but is there a certain age point that you get to that you can be able to tell? And is that as an adult, or does that happen in the younger ages?
Well, let me start by addressing the age question. And there are so many genetic conditions out there, and the number that are being recognized is growing every day, to the point that the books I used to look at went from being one book to 3 to 5. Now it's too much to put in book form, so it's on the internet. So knowing that information is growing so much, and there's so many different conditions out there, the age at which you anticipate something like that could manifest, sometimes it's at birth. Many times it's something that shows up later in adulthood. And that's one of the reasons, actually, they mentioned LTC, and LTC being restricted in that way currently in this state. And the reason why that hasn't been as problematic is that most people who buy LTC coverage are between age 50 and 69. By then, most of the inherited conditions that are at the highest concern have already manifested. And so genetic testing isn't as much of a concern within that population. Now, as far as getting back to your other question with someone who's adopted and family history, most of the time, the people who are applying as adults for us, if they are adopted, they may not have family history. And in absence of family history, we would never hold that against someone. While for clinical purposes, out of an extra degree of caution, a clinician may decide to be more careful and do earlier screenings for mammograms or colonoscopies or different things where we have obviously clinical protocols for preventive medicine and screening. That's something obviously they may do, but from an insurance medicine standpoint, the absence of that information just means we have symmetry of information. You don't have information, therefore I don't have information, and so we won't hold it against anyone.
You're welcome. Absolutely. Absolutely. Yeah, and Delegate Hill agrees. Delegate Bagno.
Thank you, Madam Chair. And Mr. Celentano, I just wanted to flag with you. It doesn't appear that we have the MIA letter. So we'll need to make sure that we have access to that.
The MIA letter just came about 2 minutes ago.
There we go.
I
Okay,
just saw
thank you.
it.
They must be watching.
It popped up on my phone.
I have the Senate letter. I'm happy to send it to you by email.
Thank you very much. And I'm sorry to drill down on the same question, but I want to make sure that we're clearly understanding the concerns of this bill. Because I know you and I apologize. I don't remember your name, but you had mentioned the inherited characteristics as a concern. But in the context of that is derived from a genetic test about chromosomes, genes, gene products, or inherited characteristics that may derive from an individual or a family member. And then later in the bill, it does say use, I jumped to the wrong place. This section does not prohibit an insurance carrier that offers, issues, or delivers a life insurance, long-term care insurance, or disability insurance policy or contract in the state from accessing an applicant's medical record as part of the application process.
Correct. I would argue that the genetic testing is also part of the medical record. So if the genetic testing is being restricted in the bill, I'm not seeing how characteristics manifested in family members is something we can still use when it's part of the medical record.
If I can follow up, just so I'm understanding, so the reference in the earlier statement, you think could be, could make all of those exclusive, even with the prohibition on that it does not prohibit an applicant's medical record. Is that correct?
I'm understanding that us having access to the medical record does not necessarily negate the earlier statement saying that and indicate that family history would be able to be used. Now, every company may have a different interpretation of that, but giving us access and permission to use what's in the medical record, I would argue the genetic testing is also in the medical record. And if that is being pulled away, then I don't understand how family history and other inherited family characteristics are not potentially taken away from our ability to review.
Delegate Bandari, followed by Taveras.
Thank you, Madam Chair. Have you seen the letter from AZ office, Attorney General office?
Nope.
Okay. Yeah. I could read out one or two sentences. If they're right, if consumer fear being denied insurance based on the result of genetic testing, the consumer will instead not do the testing. And this is a health committee, as you guys know. Genetic testing may be very relevant to the individual healthcare or lifestyle decision and may be used to trace ancestry, right? And it is critical to research into curing or treating disease or developing the medicine. So do you want to the response to that AG letter?
I haven't seen the AG letter, but I do have the Maryland Insurance Administration's letter in front of me, which obviously has oversight of all of these products. And their take on that sort of angle is this bill appears to protect individuals with genetic conditions with from adverse underwriting decisions. But the MIA is concerned that prohibiting insurers from considering the results of genetic tests is more likely to be detrimental to individuals, particularly those who may have had a family history of diseases that have both genetic and non-genetic risk factors. Additionally, since life, LTC, and disability insurers would still be permitted to underwrite individuals based on information in the medical record that does not have a genetic component, this bill could be viewed as discriminating against those who have diseases that lack a genetic cause. So that's sort of the root of this issue to us. If you don't have the genetic information as a part of the medical record, you're going to fall back on other factors, and that might be family history. You might have a marker that we talked about earlier that says you're not going to get ALS, but if we don't have that information, we're going to go to family history. And if you have a family history of ALS, your rate's going to be much higher. So taking away any information from the life insurers is going to lead to negative consequences that let us write a policy just to you. We have to I hate to say it over again, this is not health insurance. This is life insurance, and it's underwritten to develop the best risk score based on your history and your medical record and your behavior. And we want to keep it as cheap as possible because we're in the business of selling life insurance.
Okay. Delegate Taveras.
I think he just answered my question.
Okay, thank you. Seeing no, Delegate Guzoni.
Because I'm really trying to follow along here. So I'm curious because I believe that as part of the sort of getting life insurance process, you get asked about family cancer, heart. So I have to stick in the ALS space. Wouldn't that be a legitimate question to ask? Do you have a family history of ALS?
It could be a question. I don't know that every insurance company includes that on their
Sure.
medical history questionnaire, but it could be a question.
Okay. Again, I'm just sort of struggling here.
Right. But understand that I think they've even said that around 90% of people who have ALS, it's thus far from what we understand, it's not genetic in the vast majority of people.
Sure. Okay. Yeah. And I just was thinking about the gentleman who was speaking about his family, which is obviously a terrible and tragic and heart-wrenching situation.
Yes.
So, yeah, I think, just to be clear, it's not really a question at all, but I'm struggling with this distinction between genetic and health because they're kind of tied in my mind. So just leave it at that.
Thank you. I was gonna say you could have her questions for tomorrow too, but you're okay. All right. No other questions? All right, thank you so much for
Thank you for
being
your
here
time.
with us. We do have one more witness, a favorable one that is virtual, John Knowles. Mr. Knowles? Is he there? He's joining right now. Okay, great. Thank you. Good afternoon, Mr. Knowles. How are you? Will you be so kind and unmute yourself? Mr. John Knowles?
Yes, hi.
Yes. You can get started, sir. Good afternoon. Welcome to the Health and Government Operations Committee.
Hi. Good afternoon. Thank you for the opportunity to speak with you today about House Bill 982, the Genetic Testing Protection Act. My wife, Terry, was diagnosed with ALS in March of 2021. Her identical twin sister died from it in 2013, and her sister, Patty, died from it in 2020. When Mary was diagnosed, there was no history of ALS in our family. Diagnosis was done through a process of elimination, as there are no blood tests or any tests for that matter that confirm the diagnosis. There are, however, genetic tests that indicate a person may have a gene that is linked to ALS, but even these tests only provide a possibility. Terry comes from a family of 7 sisters. All are married and together produced 16 children, and currently a next generation of 5 children with 2 on the way, including our first grandchild. The children, including my own, are all at a time in their lives when they're marrying and adding to their families. Several of them have undergone genetic testing, but most of them have not. It's sobering when the geneticist tells you that if you carry the gene defect related to ALS, you should get insurance before you get tested. There are some treatments today that help to slow the process of ALS, but the future hopefully holds the possibility of treatments that can relate to non-symptomatic patients who have the genetic defect, but without genetic testing, Maryland citizens who could get early proactive treatment won't, because they put it off due to concerns about life insurance. Today, my wife, Terry, is slowly getting weaker. Last year, we attended these hearings in person, but this year she's homebound. The progression of her disease is following the same path we saw in her sister's. She is on 3 of the drugs approved to slow the disease. She is part of the ALS program that will develop experimental personalized therapies to treat patients with rare genetic forms, but this may not come in time. I mentioned earlier that some of our relatives have undergone genetic testing. They did this in order to be involved in a national study that is following the relatives of patients with familial ALS to try and learn why some people develop it and others don't. With that said, they underwent testing, know that it may have a negative impact on them, but hopefully will assist in finding a cure. For our family and others like us, the passing of this legislation will take away one worry and will provide an avenue for those who want to take genetic testing to discover if they have a gene defect, to be open to being involved in studies for future treatments. Last year and today, one of the people against this legislation told us that if it's passed, anyone with a defect will get as much insurance as they can afford. When Terry and I retired, we followed the suggestion of our financial advisor and we canceled our life insurance since we don't need it to pay for our home or for our burial. Not everyone is as mercenary as some folks believe. I'll close by simply saying this. If you, your family, or your friends have never been impacted by diagnosis of ALS, be thankful. Watching your loved one slowly become weaker, eventually losing strength in every body muscle is heartbreaking. Thank you for taking the time to listen to our story and for your support for this important piece of legislation.
And Mr. Knowles, thank you for sharing your story, okay? We really appreciate it. I'm so sorry. Are there any questions for Mr. Knowles? Seeing none, thank you for being patient and for being with us today. Your presence really matters, and I hope you have a blessed day.
You too.
Thank you. This actually concludes the bill hearing on House Bill 982. Next, we have House Bill 755, Delegate Bandari, State Board of Social Work Examiner Board Membership, Certified Social Workers Licenses. And on your panel, you have Karen Richards. Is Ms. Richards here? Ms. Karen Richards, will you be so kind and come up? Actually, she's virtual. Can you bring her up, please? Now, that would be the day if you can come through in virtual. Go ahead.
This is very short and sweet bill after genetic testing. Chair and Vice Chair and members of the committee, this is very simple bill designed to
don't ever say that.
Designed to streamline and clarify the licensing and board membership process for the State Board of Social Work Examiners. It removes outdated reference to certification, no longer in use, and that align our practices with the current standard. And the expert is here virtually. Andrian Ikas, the Vice Chair of the Maryland Board of Social Work Examiners and the educational representative on the board. She brings the wealth of experience to this discussion, not only from her leadership role on the board, but also as the Assistant Dean for Field Education at the UMBC School of Social Work. And thank you, Madam Chair, for doing the heavy lifting on this bill.
You're welcome. Good afternoon. Ms. Richards, you can get started.
Good afternoon. I'm Karen Richards, and I am the executive director, the new executive director of the Board of Social Work Examiners. Thank you, Chair and Vice Chair, for letting me speak. The board is in support of this bill. It again, as stated earlier, it's a cleanup bill. We are eliminating the LCSW level of licensure, and this bill just kind of cleans up the language, and we're in support of the bill. Thank you. Do you have any questions?
Thank you. Let's see if there are any questions. Are you ready?
I'm ready.
All right. Are there any questions for Ms. Richards? None. You did such a great job. There are no questions. And this actually, if you could be so kind and come to the subcommittee, please, when it's scheduled. In case there are questions, then Delegate Bandari, this concludes the bill hearing on House Bill 755.
Thank you.
It was very simple. You proved me wrong.
Thank you.
You're most welcome. We have Delegate Bogle. Is he here? He's not here. Let's go on to Delegate Kerr. All right. Thank you so much. Well, let's see. Delegate Bobo, I called you and you were not here, so I called another bill, but I'm gonna go ahead and let you come forward, okay? So we're gonna call instead Delegate Kerr, if you will be so kind. He has arrived. Thank you. This is House Bill 736. And if you will be so kind and bring your panel, I believe is Deborah Burrell. And you can get started.
Thank you, Madam Chair, and I apologize for the delay. We are about to start a voting session down in Ways and Means.
Okay, thank you.
I have a bill here, House Bill 736, that I will ask for a favorable report. This bill is in response to the fentanyl overdose epidemic that we're seeing and a recognition that expanding access to naloxone, commercially known by the brand name Narcan, can help reverse overdoses. We've seen that Narcan can reverse up to 93% of overdoses, and it reportedly saved 27,000 lives across the country. The FDA authorized Narcan, naloxone for over-the-counter use last March. But the cost, if you walk into a pharmacy, you will see that it's currently being sold for $40 to $60. So this legislation would require insurance coverage. Medicaid is already covering it. This would require private insurance coverage for naloxone, for Narcan, and set a maximum copay of $10, capping the cost of over-the-counter Narcan at $10 for all Marylanders. With that, I will just note that we have checked with MIA, the Maryland Insurance Administration, and their assessments from their actuaries are that they would not see that Marylanders would not see a premium impact with this piece of legislation. I look forward to hopefully working with your committee on this bill and ask for a favorable report.
And did you meet with the insurance carriers?
We have had conversations with them. I know that they have testimony on this bill as well.
All right, but in your meetings, did you meet with them and try to work it out?
Yes.
Okay.
I'm not sure if we see eye to eye yet, but
Okay,
we wanted to make sure there would be no impact on premiums, which MIA does not believe there will be.
okay, but if their testimony is unfavorable, which it is, I need you to meet with them and try to work it out, okay?
Yes, Madam Chair.
All right, how are you?
Good afternoon, Madam Chair and distinguished committee members. I greatly appreciate it. My name is Debbie Burrell, and I've been before the committee. I'm here in support of the intent of House Bill 736, which continues coverage of overdose reversal drugs that are now available over the counter and capping the price. I've been involved in this issue for many years. I've known many of you over the years. I worked for Congressman Bartlett. Our district was the highest in the nation, District 6, which Mr. Trone represents, in terms of overdose. We also still see a lot of inconsistent policies across the state when it comes to even things that are from the HOPE Act that are being executed. For example, the ER discharge protocols, and I'll get to that in a second. But what this bill really tries to do is expand naloxone access and make it affordable for those who need it, which in many cases in the state is family members of loved ones. It's people that don't know that opioids are still addictive, that their doctors have prescribed to them. And it's for innocent bystanders, people in schools who want to be helpful. Because we're seeing those overdoses in places where I would like to say we're not seeing them, but we're seeing them in schools, restaurants, bars. We're seeing them at Publix restrooms. So we do know that availability to naloxone is super important. Personally, I've lost one of my closest friends for this. I'm here as the Maryland board member for Strengthen the Mid-Atlantic Region for Tomorrow, which is a caucus of the 40 members from Maryland, Pennsylvania, Delaware, and New Jersey, really on that I-95 corridor. And that 501c3 actually works with the members of Congress who are seeing this federally. Each year we appropriate $1.5 billion to this epidemic. What the bill tries to do, and personally I've seen this issue, is to create consistency among the insurance policies so that naloxone can be where it is needed. I went through cancer treatment last year, and I was prescribed naloxone with the opioids that they gave me. And I was given it for free because I have Care First Blue Cross of Maryland through the state exchange. However, I had a subsequent treatment because of just going through the complications, like a different hospital in Maryland. And I was actually not even offered naloxone with the high dose opioids, and then found out it was a tier 3 under my plan for $50. So one hospital covered it as a co-prescribed, another when I went to the pharmacy because it wasn't prescribed, it was a totally different, yet the same person, same patient, same condition. Just want to make sure that there's consideration as you look through this, and we do intend to meet with the insurance industry to help work out the issues with it, because it's really about making sure naloxone's where it needs to be when it's needed.
Okay, thank you. And thank you for your work, and thank you for sharing your story. And I'm glad you're doing better.
Thank you.
Thank you. I'm going to open it up for questions for the delegate and his panel. And I do see to my right, Delegate Hutchinson, followed by Delegate Lewis, followed by Delegate Hill.
Thank you, Madam Chair.
You're welcome.
Delegate Vogel, thanks for bringing this bill to our attention. Just so I understand it correctly, though, so this is to get the private insurance payers to pay for this through a copay. Typically, when I go to the drugstore to buy something and give them my card, I'm getting a prescription for me. Is this that I would be getting this for me in the case I had an overdose, or are we allowing this so that is the purchase of Narcan through my private insurance to be given to anybody that may need it?
Standing order recovers for anyone. I know you were addressing him. Would you like me to? Okay, sorry. So I understand under the standing order, so that allows for the purchase of Narcan. Because the epidemic is such, generally for insurance, it's a one-to-one, but the insurance companies like United Healthcare and others in the state have now covered Narcan. If I go up to the pharmacist and ask for it, if I had United Healthcare, they would cover it for free. If I had TRICARE as a military retiree, they give it for free, whether I was using it just because under the standing order I was asking for it. However, not all policies in the state of Maryland are consistent. They're not supposed to ask if it's for you or for somebody else because of the epidemic.
Thank you. Delegate Lewis.
Thank you, Madam Chair. Thank you, Delegate Vogel and your panel. I am a little confused, and it's entirely possible that I've had too much caffeine and not enough sugar, but I hope you can help me understand. Now, I thought that naloxone was publicly available over the counter. So, and I believe it's relatively affordable. The Google machine haven't got that far on the searching prices, but I think it's universally available over the counter. So I'm not understanding why Medicaid is involved in this, why we're talking about a price cap for a product that's available in the private market over the counter.
Well, thank you, Delegate. So there are a number of different ways to obtain naloxone. The FDA authorization is such that now, really for the first time since March, I see it, I shop at Harris Teeter, and if you walk up to the pharmacy at Harris Teeter, you see the box standing there. That was because of the FDA authorization for over-the-counter sale. That, if you go buy it through the over-the-counter method, you're looking to pay at that Harris Teeter, it's $45, but you're looking to pay between $40 to $60, which prices out a lot of folks in our state who, this is specifically for individuals who say, I want to buy that. I might not need it right now, but I want to have it on hand, which we want more folks to have access. But $50 is not something that, folks are just able to spend money on right away. A $10 cap would make it accessible to more individuals who choose to get it through this route.
Yes. Thank you, Delegate Vogel. So I see your point. Making a product, a life-saving product, more widely affordable is a noble, mission, and I support that. But I'm aware that there are, for folks who truly can't pay out of pocket at those prices, are there no other resources? There are nonprofits or needle exchanges. There's all sorts of places where people without the means could access the product. There are drug treatment centers, outpatient centers. I just don't, I may just not be getting the mechanism that you have in mind, but there are ways to get this life-saving medication that don't involve out-of-pocket expenditure.
There are, Delegate, yes. Our intent with this bill, and there are a number of intents when it comes to generating more uniformity with the standing order for over-the-counter medication and the medication that you would get via a prescription. But in addition to that, what we are trying to ensure is that this drug is available, this medication is available to as many people as possible. And there's a reason why FDA allowed this to be accessible over the counter. What we want to ensure is that with that step, we make that available to as many people as possible by not pricing people out from being able to buy it over the counter.
Delegate Hill.
Thank you, Madam Chair, and thank you for this bill. Just have one question. There's now another opioid blocker called Opvee that's available. It is prescription out over the counter. And it lasts longer, so it stays around. It's less relapse, and with fentanyl being a much of increasing use, and the Opvee or nalmefene seems to do a better job of reversing fentanyl overdoses without having to repeat. So would you also want us to require that be covered as a reverse opioid reversal drug as well, or just the naloxone?
So Delegate, I appreciate that point, and I will note, we are looking to cover any other drug or product that is approved by the FDA for the complete or partial reversal of an opioid overdose. So if that's the case, and I would hope to work with your committee to make sure that and with you using your leveraging your medical expertise to make sure that the language accounts for that. I think the one question that I would have is whether that is currently available for over the counter sale, or whether that's exclusively Narcan right now.
It's concerned about whenever we double down on prescribing a particular product and creating the market for just that product, what the unintended effects are. And since there is another product, although prescription, that is available, that's why I was asking. Thank you.
Thank you.
So I have a question. I don't see any other. Oh, let me just ask the question before I forget. Did you see the letter from the department?
The Department of Health?
Department of Health
Yes.
and the fiscal note?
Yes. So we have two amendments that we just got the draft back. I can circulate it. I can send it to you, Madam Chair, and circulate it to your committee.
To the attorney, you have it?
They sent.
Okay, great.
And that per the email that we received from the department that addresses their concerns.
How are you going to address the $3.2 million annually that they will have to spend and hiring people? And does it get rid of all of that? Because it says that under this scenario, Medicaid expenditure, it says, does it strike Medicaid out of the bill?
It strikes Medicaid. Medicaid already being covered by the standing order.
Okay. And then they have some other concerns in there about the bills, but you're working it. It seems like you're working the bill.
Yes, Madam Chair.
All right. Delegate Taveras.
Okay. Maybe I'm just trying to make sure, does your bill make any accommodations for individuals that are not insured?
So Delegate, under the state currently does cover Narcan under the standing order for individuals with Medicaid, and sets a copay cap for them of $1. So under Medicaid, they're already insured. For folks that aren't insured at all, that's where, back to Delegate Lewis's point, under this bill that would not make those accommodations, but there are thankfully other resources in the community that make Narcan available to them.
Okay. All right, I'll try to investigate what those sites are that provide Narcan. But I'm just curious because I had not heard that they were freely available. And just for the record, it is from anywhere from $20 to $60 per saving kit. But thank you.
Thank you, Delegate.
Any other questions? So Delegate, because you don't get an opportunity to come back, we're gonna do the unfavorable. Just make sure that you meet with the parties and try to work it out before it goes to subcommittee, okay?
Will do, Madam Chair.
Thank you
Thank you.
so much. And great to see you, ma'am. Thank you
Thank
for
you.
coming and sharing your story.
Thank you.
Thank you for being patient as we ask the questions. We have next the unfavorable panel, which will be the League of Life and Health Insurers of Maryland, Kaiser Permanente. Good afternoon.
Good afternoon again, Madam Chair, members of the committee.
I
Still,
don't envy you. Go ahead.
well, I'm still Matt Celentano, and I'm still here on behalf of the League of Life and Health Insurers in opposition to House Bill 736. We are very supportive of trying to get Narcan out into the community. For the good of this committee, we want to relay that Narcan has a blanket prescription you've already heard and is available over the counter. I had a discussion with the proponents prior to the hearing, and I totally understand where they're coming from. I would love to talk about ways to get more Narcan to the folks that need it. You've heard that the MDH Overdose Response Program, or ORP, allows for FDA-approved opioid reversal drugs to be offered to specified individuals free of charge by multiple providers, programs, and entities. And MDH must purchase and provide MDA-approved opioid overdose reversal drugs at no cost to the entities who may provide the reversal drugs when MDH provides them. They also, if you were watching the Super Bowl, many of you might have been, there was a local commercial from MDH prior to kickoff that talked about Narcan and opportunities for the public to get free Narcan. They're doing a great job of education, and we want to continue to highlight this. We do have structural concerns about the insurance portion of the bill. It requires coverage of a drug that isn't for the beneficiary. When you buy insurance, you are buying a product to cover your health. This bill isn't that. This bill requires coverage for a drug for someone else. We already require the coverage of Narcan in 15850. You can't give yourself Narcan. And if you're in the midst of an overdose, this coverage falls into sort of an uncertain place. We're also concerned about the price cap in this legislation. About 10 years ago, when Narcan was not as widely recognized as it is now, it cost about $1 a dose. When the popularity rose and all emergency providers were required to carry it in their kits, it went to $40 a dose because the manufacturers could. This drug is a classic example of why we need to continue to work on the Prescription Drug Affordability Board, because this is going to create more problems, not less. Thank you for the opportunity, and I urge an unfavorable report.
Thank you. Next, please.
Good afternoon, Madam Chair and members of the committee. My name is Allison Taylor. I'm here on behalf of Kaiser Permanente. To pick up where my colleague left off, I'm looking at some data right now from the University of Southern California that showed between 2014 and 2018, a huge increase in the cost of naloxone for individuals who are uninsured, where at the same time, the out-of-pocket cost for patients with insurance remained about the same. And this relates to the dynamic that Mr. Celentano spoke to about rising costs from manufacturers for this product. This bill doesn't speak to the uninsured. This is about insurance coverage. So we think it's attacking the wrong piece of this problem. Last thing that hasn't been mentioned, and I do think the sponsor is open to amendment on this, though, is that at a retail counter at a pharmacy, there's not a mechanism actually to bill insurance. If this were, I see he has an amendment looking to limit this to pharmacy counter only, which would be beneficial. But otherwise, if it's, you're just going up to the front counter at a Target or something, they don't have a billing mechanism. And so a patient could submit a claim or something like that to cover this, but it wouldn't, it's not as seamless as might be made out to be. So certainly some work is needed. We think there's better approaches to increasing availability of naloxone. So we respectfully urge an unfavorable report.
Thank you for your testimony. Delegate Chisholm.
Thank you, Madam Chair.
You're
And
welcome.
this is for either one of you. Matt, you probably better to answer, but do you know who the manufacturer of naloxone is? Yeah.
There's a couple of them. I think Narcan. I don't know. We could look it up.
We could find out for you. Yeah, because I'm considering market forces and when does the patent run out? Obviously, they're producing it at the same cost as they were for $1 as they are for 40. So when the patent runs out, hopefully it'll open up the market a little bit and bring down the prices through the free market. I don't know if that's a possibility or not. Just curious about that.
Well, that's always the hope, Delegate Chisholm, is that once the patent runs out, there'll be generic competition. But as you have heard time and time again, there are all kinds of forces that prevent sometimes that happening, including a scheme called pay for delay, where the brand manufacturer will pay the potential generic companies not to bring their drug to market because they want to continue the monopoly. We've seen that in all kinds of drugs, and we don't want to see that continue to happen. But that is just sort of the place we are with the unregulated manufacturer space.
You're welcome. Delegate Lewis.
Thank you, Madam Chair. It looks like the patent for naloxone is held by held by a Maryland company, which is nice. And it's made by Emergent Biosolutions. But anyway, thank you for your testimony. And I wasn't 100% aware that naloxone is available for free. So that makes sense for people who may be struggling with housing insecurity, unbanked, without health insurance, although we want everyone to have insurance in the state. So just to make sure that I'm understanding, people who would benefit from the passage of this legislation, of the proposed legislation, are people who have insurance, not necessarily people who are really struggling, because people who are really struggling can get Narcan for free.
Well, anyone can get Narcan for free through the state's overdose response program.
Yes,
Yep.
thank you. Thank you. So the target population for this bill, which is people who really are struggling financially, already have another access point. Is that so?
Madam Chair, can I answer?
Well, she's asking another question, so yes, you can
Okay,
answer
thank you.
it.
I just wanted to make sure I didn't break the rules.
No, thank you.
I think it's important to point out here that, yes, I think the target population are folks that would be in Medicaid, but addiction doesn't know your annual income. And it's important that we do make sure that everybody gets a chance to have these kinds of drugs. But the folks that might be in the higher end is already covered with their insurance are not going to really benefit from this bill. It's not at a price point where it's going to prohibit them from getting it.
Thank you, Delegate Lewis. Delegate Rosenberg.
My question obviously is directed to those of you at the witness, one of you, but I think the sponsor, it's also directed at him. We have an opioid restitution fund. Have anybody looked at whether the fund, the settlement money we are getting from the purveyors of the opioids could in some way, shape or form address this problem? And then have it taken up by the opioid restitution fund board?
Delegate Rosenberg, I think that is something that we would be certainly interested in having discussions about. I talked to the proponents prior to the hearing, and I think that, everybody is for getting as much Narcan out to the community as possible. And the overdose response program, the ORP, has been doing, I think, a pretty great job. But part of this is, I think, resources, right? And if we need more resources to get more free locks into the program, maybe the restitution fund is someplace that we could look.
Thank you. Any other questions for this panel? Seeing none, if you could, our standard advice, meet with the sponsor and continue to talk and see if you can work something out. Thank
As
you
always,
so
Madam
much.
Chair.
Thank you, and I appreciate you. So next we have a panel and they're all virtual. Will you be so kind and bring all three up, please? Thank you. Ms. Travers, Mr. Kennedy. Anyone will you be so kind and unmute yourself? John?
Yep, hello.
Kennedy, I saw you first, so good afternoon and welcome to our committee. Will you be so kind and start your testimony? You have
Sure,
2
my
minutes.
name is- So
Thank
first of all,
you.
thank you so much.
Oh, you're
I
most
think
welcome.
this is an important issue, so I really appreciate the time. My name is John Kennedy. I'm with Musicians for Overdose Prevention. What we do is we distribute naloxone to music venues and to musicians, bands on the road, recording studios, radio stations, festivals. I think that this question of naloxone pricing is really important. It's not we started because we knew people who were overdosed and dying in the music scene. But when we became a nonprofit, we found out that one of the biggest kind of barriers to all work
was the price of naloxone. You know, even if it used to be $75, even if it's $50, we distribute 3,000 kits a year. That would be $150,000 worth of naloxone that we distribute a year. And for a mom and pop, you know, harm reduction organization, that's more than triple our budget. It's just impossible for harm reduction organizations to actually spend their own funds on naloxone. It's priced for government agencies to purchase naloxone at a premium and then to redistribute to harm reduction organizations like this. It's priced to maximize profit. It's priced for the state government and other state entities to purchase this at these elevated prices. You guys actually know, we actually know how much the naloxone costs because naloxone is also available in IM, the intramuscular little vials and needles as another option. And that's $1, that's 50 cents. So the amount of markup and profit on this is, you know, bad for budgets, impossible for community organizations, harm reduction organizations to purchase on their own, and priced well outside the space for users to be able to pick this up too. It's just profit over people's lives and profit because they know that state governments are going to be picking up this tab.
And thank you for your work, Mr. Kennedy. We really appreciate your testimony. Good afternoon. Will you be so kind and unmute yourself? Ms. Toller.
Hello, Madam Chair and members of the committee. My name is Ashley Toller. I'm the Policy and Advocacy Associate with Maryland Coalition of Families. We are testifying today in support of House Bill 736. Submitted is also our written testimony. Last year, we served nearly 5,000 families of a loved one with a behavioral health need, including 20% of families with substance use and co-occurring disorders. Having access to this non-prescription opioid reversal drug that can be covered through certain insurers and price cap is essential and life-saving. This will help to reduce barriers some individuals and families face when trying to access this life-saving medicine. We serve families across the state, those included in rural areas. Sometimes proximity and transportation is a barrier to accessing Narcan from sites that provide it for free, which delays having it on hand. We urge a favorable report and thank you for letting me testify today. And that is all.
Your timing was excellent. Well done.
Thank you.
You're welcome. Are there any questions for these two witnesses? Seeing none, thank you so much for being with us. We really appreciate your testimony and the work you do. Thank you. We have one last witness for this bill and it's it's actually Angela Travers. No, not on. Okay, so let the record reflect that this person is not there. So therefore, this concludes the bill hearing on House Bill 736. Next, we're going to go on to House Bill 84. Delegate Kerr, thank you for being so patient earlier. Hospitals and urgent care centers. Will you be so kind and bring your panel? And I have to step away for a meeting for a few minutes. My wonderful vice chair is going to preside over this hearing until I get back. And you have Delegate Kerr, Thomas Heyman, Barbara Brookmeyer, Peggy Towson.
My sponsor panel is Thomas Heyman.
Yes.
Dr. Brookmeyer and the Brooke and Bill DeSantis.
Wonderful. All right. You know best.
Yeah.
And you can get started.
Thank you.
You're most welcome.
Well, thank you, Madam Chair. Good afternoon, committee. I'm Delegate Ken Kerr. I'm here presenting House Bill 84, Hospitals and Urgent Care Centers Sepsis Protocol. A few days before his 6th birthday, Lachlan DeSantis was very sick. His parents, Brooke and Bill, took Lachlan to an urgent care center where they told Brooke and Bill that Lachlan had the flu. He was given Tamiflu and sent home. Later that night, as Lachlan's symptoms grew more dire, Brooke and Bill took him to the emergency department, where he died a few hours later of sepsis. As I said, this was a few days before his 6th birthday. Sepsis is a potentially life-threatening condition that occurs when the body's response to an infection causes widespread inflammation. It can lead to a cascade of changes that damage multiple organ systems, ultimately resulting in organ failure and death if not treated promptly. Early recognition and prompt treatment of sepsis are crucial for a positive outcome. Treatment typically involves antibiotics to target the underlying infection, along with supportive care to stabilize the vital signs and address organ dysfunction. In severe cases, patients are admitted to an intensive care unit for close monitoring and advanced interventions. Each year, according to the Center for Disease Control and Prevention, at least 1.7 million adults develop sepsis, and nearly 350,000 die as a result of sepsis. On average, that's about 30% of all of those who develop sepsis or septic shock will die. And the condition affects claims about 1,100 Marylanders' lives a year. By comparison, Maryland gun deaths are about 800 and motor vehicle deaths are about 600. And both of those public health issues receive far more attention than does sepsis. In my own district, a case study at Frederick Health Hospital 11 years ago found that the leading cause of death at Frederick Health Hospital was sepsis. They didn't have a protocol in place, and they didn't have a system to recognize borderline sepsis patients. The hospital's performance improvement department formed a multidisciplinary sepsis steering committee to find a solution. Without going into a whole lot of detail, I'll just point out that as a result of this committee's work, the hospital's 16% mortality rate dropped to 4% and remains there today. So while sepsis can be a life-threatening condition, many people do survive with timely and appropriate medical care. What House Bill 84 does is requires urgent care centers and specialty hospitals and state hospitals to educate the staff on screening and early detection of patients with sepsis, severe sepsis, or sepsis shock, and transport these suspected cases to a hospital facility capable of treating sepsis. In addition to training the staff to recognize sepsis, full-service hospitals with emergency departments and intensive care units who are equipped to treat sepsis are required to establish a sepsis treatment protocol as specified on page 2 of the bill. In 2018, House Bill 1467 established a sepsis public awareness campaign work group, and some of you in here were co-sponsors on that bill. The work group completed its study and issued its final report in August 20th of 2018. A final recommendation was future efforts in Maryland should focus on sepsis education and awareness for healthcare providers. One recommendation was a Sepsis Awareness Month proclamation that Governor Hogan did issue in September of 2018. However, 15 months later, Lachlan DeSantis died from a lack of awareness. Lachlan's parents, Brooke and Bill, are here with us today, and I will invite them to tell you how they've turned their tragedy into a foundation with a mission of preventing, educating, and driving awareness of the deadly impacts of sepsis and flu, and how House Bill 84 is central to the Love for Lachlan Foundation and mission. But first, I would like you to hear from Tom Heyman of the Sepsis Alliance, and then Dr. Brookmeyer from the Frederick County Health Department before hearing from Lachlan's parents. Tom.
Thank you, Delegate.
Thank you,
Mr.
and thank you
Heyman.
for having us today. My name is Tom Heyman. I'm the president and CEO of Sepsis Alliance. We're a national patient advocacy organization. Sepsis is common, expensive, and deadly. In fact, 1 in 3 people who die in a hospital are dying of sepsis. 1 in 3. More children die of sepsis than cancer in the United States. Sepsis is deadly and disproportionately affects medically underserved communities. About 40% of patients who are lucky enough to survive require readmission to a hospital within 90 days. Imagine the suffering on those families and the cost to our healthcare system. 14,000 survivors require amputations each year. Again, a lifelong concern and cost burden. In fact, 1 in 3 of us will get sepsis in our lifetimes, and 1 in 15 of us will perish unless we do something about it. Lauchlin's Law will provide life-saving sepsis protocols for hospital settings and urgent care settings alike. These protocols can and will save lives and limbs. Another vital component of the bill is education and training. Sepsis Alliance has the Sepsis Alliance Institute, where we've trained over 45,000 healthcare professionals across the continuum of care, school nurses, first responders, home health aides, hospital staff, to be better aware of the risk of sepsis and how to diagnose and treat it effectively. Sepsis is fast-moving, deadly, and difficult to manage. Its symptoms can easily be confused with other diseases. Training and education are key. It's also important urgent care be included in this because 87% of sepsis cases are present on admission to the hospital. We mostly think of sepsis as a hospital-oriented disease. 87% of cases are treated initially in the community, making urgent care an ideal opportunity for early diagnosis and treatment. Thank you very much.
Thank you. Ms. Brookmeyer.
Hello, I'm Dr. Barbara Brookmeyer, the Health Officer for Frederick County. Thank you for hearing this bill today. The components of this bill are the next reasonable step in the statewide initiatives. It will respond to the stalled improvements that were seen from the prior statewide initiatives. In Maryland, septicemia was the 9th leading cause of death in 2021, the 9th leading. And when we look at the age-adjusted mortality rate for Maryland compared to the US, Maryland is higher than the US. That lets us know that there are gains that can still be made. And then when we look to see whether there are racial disparities, they are quite evident in Maryland as Black men die at greater rates, almost 19 per 100,000, than Black women, white men, and white women, who are almost half the rate of that for Black men. In Frederick County, 38 people died of septicemia in 2021, and that's actually more than the numbers of persons who died from chronic liver disease and cirrhosis, more than the number that died from suicide, than breast cancer, and by motor vehicle accidents. So while deaths from septicemia most commonly occur in adults over age 55, and that's what many healthcare providers might be thinking about, it can occur at any age. When time matters, early recognition is critical. And protocols, that is system infrastructure that's put in place, are particularly effective at reducing health disparities. Thank you.
Thank you. Mr. and Mrs. DeSantis, who was going to go first?
Thank you for having us today. My name is Brooke DeSantis. We're here today in regards to Lachlan. The reason we are asking for this change, he lost his life to the misdiagnosis of sepsis treatment stemming from influenza. Friday, January 17th, 2020, he became symptomatic after school, stating legs and headaches, or leg cramps and headache. I apologize. By Sunday night, he took a turn for the worst, seeking care at the top-rated urgent care due to stating that they provided emergency care, inquiring several times if I should be there or go to emergency department, and they declined. Monday afternoon, January 20th of 2020, less than 12 hours after seeking care, he passed away. He was one of 9 pediatric deaths in 4 weeks in our county. The education policies and awareness didn't just fail Lachlan, it failed all of us. Seeking treatment for our son and trusting the advisement of all staff I encountered, they didn't have to live with the weight of images forever with you of the last words. Not being able to save your own child. Coming home to the brothers telling them what happened and seeing him in his coffin. Our story may be different if I was directed to go to the ED. When they couldn't detect a blood pressure, the excruciating pain that he was in. No one should have to hold their child for the last time. This is to see no one ever has to go through what we did or any other future for those who have loved ones too. Providing support and awareness and prevention since he left us has become a mission. working in collaboration with those in the state of Maryland and the nation to bring this to light, saving lives as possible. We can't do this alone. I ask that you support this bill for not just us, but for the state of Maryland.
Thank you. Mr.
Um,
DeSantis?
Lachlan's father, Bill, is here in case anyone has any questions for him. He doesn't have any testimony.
Thank you. Mr. DeSantis?
Thank you. No, I'll stand up. How's that? Thank you very much. I just want to say I appreciate everyone's time today in helping us fight this mission. We have made it our mission to help prevent this, and this bill is holistically part of that. So thank you, and I hope all of you are willing to join our mission with us.
Thank you. And Lachlan's brother is here, you said?
I'm sorry?
Did you say Lachlan's brother is here?
No, his father.
Father. Oh, okay. I'm sorry. Thank you all for your testimony. I'm sure I speak on behalf of the entire committee to give you our condolences and deepest sympathies for your loss. Are there questions for the delegate and his panel? I am seeing Delegate Johnson first.
Thank you, Madam Chair, and thank you for bringing this bill and some testimony. I see a couple letters of opposition. Could you go over those letters with us?
Tom, you ready to take that? I think doctors. Senate doctors.
Sure. Hi again. I'm Dr. Barbara Brookmeyer from the Frederick County Health Department. I'll try to summarize what I've reviewed, and I believe they're all of the letters that have come in, and I listened to the testimony that we just had on the Senate side. So some of the concerns are that are about protocols and concerns that protocols might be too rigid. And I think the people who will be speaking after us, if we'll have the same folks speaking in support of this that spoke on the Senate side, you'll hear from them that they actually do welcome protocols as a way to actually standardize the treatment. And again, as I mentioned, it's protocols have been demonstrated to be particularly effective at reducing health disparities. So reducing disparities in the way people are initially managed and their condition is recognized. They can also, protocols can be modified as new information becomes available. And when a clinician is working, is taking care of an individual, it is about the individual. And so what the protocols do, though, is the protocols help to identify that the signs and symptoms of, what's going on with the patient are consistent with what could potentially be sepsis. And so it still allows for the part, which is the whole art of medicine, but it helps, though, to have what we call in the differential diagnosis. It helps to have higher on that differential diagnosis. Oh, could this be sepsis? And if it is sepsis, what else do I need to be doing as a clinician to be tracking, to be seeing, checking, could this be? And if it is, what is it that I need to do now to start preventing it? There were also some concerns about maybe this is with a protocol that it might be leading to overuse of medications. And in fact, I would say that with a protocol, ideally, and the training, that earlier detection will help prevent somebody from getting so sick that the whole, kitchen sink is thrown at folks, or whatever that phrase is. You actually can hopefully utilize fewer medicines if somebody's condition doesn't get to the point where they have multi-organ failure. And then I think that covers it. If there's anything else, others can pipe in.
Delegate Johnson, okay. I have Delegate White Holland and then Delegate Riley.
Thank you, Madam Chair, and thank you, panel, for being here and sharing your story. I wanted to address the amendment that we see at our desk that was proposed by Delegate Kerr, and wanted to inquire if this simply addressed some of the concerns outlined by those who are favorable with amendment. So does this amendment address those specific concerns?
Thank you, Delegate. Yes, that's the intent of the amendment. We did meet with the Maryland Hospital Association, the Maryland Department of Health, who had concerns that they run the state hospitals. The state hospitals are not equipped to treat, as well as other specialty hospitals. And we met with representatives from the urgent cares. What the amendment says is that if you are a specialty hospital or a state hospital or an urgent care, what we want you to do is train your staff to identify sepsis, and when it is suspected, transport the patient to a facility capable of treating it. And what that is, in the amendment, it says hospitals with intensive care units, emergency departments are the ones where we want them transferred to. So I believe that our amendment has addressed the concerns of all of those with favorable with amendment.
Thank you. Delegate Riley?
Oh, thank you, Madam Chair. Thank you. Most of my questions from Delegate Johnson, some of them have been answered, and I took the vice chairs and doing Dr. Google here. So it does help. So I was looking at some of the symptoms, and I mean, it could be from pneumonia, bloodstream, or what, I mean, it's basically from an infection, but that infection can come from several locations. So when we're trying to identify it, it sounds like there's definitely not one test that can be done to see if it's sepsis. Is that true? First of all, is there something that is in the medical field that can actually determine whether they have sepsis or not?
I'd say,
Like a blood test or?
that is one of the huge challenges, and why leaving it up to individual anecdotal experience and looking at things, looking at the data and at the patient in front of you makes it particularly challenging. And that's where having protocols and from Sepsis Alliance, then you've investigated even more deeply what are some approaches beyond protocols that can help help to improve the early recognition of the potential. So Mrs. DeSantis mentioned blood pressure. So that's one of them. Blood pressure is routinely checked. Heart rate goes along with that. So there are some other indicators that someone's condition is worsening. And with artificial intelligence, I'm hoping that 10 years from now, we will have something where an algorithm would be able to detect it even sooner than the artist and the scientist that is managing an individual's care.
Okay.
But
so
the
Madam
Sepsis
Vice Chair,
Alliance can speak.
could I have a
Yes.
follow-up?
Yes.
So what you're saying is that this particular legislation will come up with a group of things that the doctor or the place should look at to give you a better idea that something else like sepsis is happening with the
Yeah,
patient.
so I would say with the protocol, it outlines well, and I haven't looked at the CMS ones. We had dialogue over on the Senate that there was support for what the Centers for Medicaid and Medicare Services have as their protocol. But it's when you're identifying this, when you see this, think about that and manage it from there. But
Thank you very
it's to raise in one's mind, again, we call it the differential diagnosis, but what that sepsis could be what's going on. And in order to be tracking to see whether sepsis is occurring and whether it's getting worse, these are the things that you'll want to do. If you haven't taken blood cultures, you'll want to do that, if you know.
Thank you. Delegate Hill, your question was answered?
But I can skip it. It's fine.
Okay. I have a question, Mr. or Dr. Heyman. So you are a nationally based organization, correct? Sepsis Alliance. So would you, in your opinion, believe that this bill reflects some of the best practices that you and your organization have seen in terms of addressing the issues of sepsis?
Absolutely. And, with New York in particular, but Indiana, Illinois as well, now following suit, we've seen an improvement in mortality as a result of the protocolization with flexibility at healthcare centers. I think what's innovative here is the addition of education and training, which is very, very important, because it's one thing to give people tools and then tell them to go use them if they're not really trained on how to use those tools. So we think that's very important. Also, urgent care is innovative here. So I think Maryland has the opportunity to really be on the cutting edge here by moving upstream in the care process, given how many patients are going to urgent care first. We all know this from our experience. And if those centers aren't thinking about sepsis when it's one of the most common things coming through their doors, we really lose an opportunity, like we did with Laughlin, to get the suspicion diagnosis in early and get a transfer to hospital done urgently.
Great, thank you very much. Are there any further questions, Dr. Hill, Delegate Hill?
Sorry, I figured out what it is that so we're putting this in statute. I think it's an important issue, protocols and all that. But we talk about must transfer without any reference to stabilization, right? So to transfer, there's an obligation to stabilize the patient first. And my concern is, since you've had these protocols and introduced them around the country, how do you deal, whether it's an urgent care or some other place that clearly doesn't have ICU ability and they can't treat the patient long-term? What is the legal obligation if we're mandating transfer, if they're not able to stabilize the patient and the patient dies on the transfer? I'm concerned about that issue.
Dr. Brookmeyer, is that?
That's a good question. I would say that if somebody is that ill, well, I would think that the stabilization, that if a facility doesn't have all the treatment that's available to begin with, then they're actually not even able to provide it prior to transport. And it could be that the transport vehicles are actually better prepared for those emergency situations than what a facility, if we're thinking about, like, say, some of the state hospitals. So I'm sure the state hospitals have something, if somebody has a heart attack, they have an AED. But when you're talking about, are they prepared to put in an intravenous line? Are they prepared to put in an intravenous line, in intraosseous one? You know, if they can't get, because the blood pressure has gone down so low, they can't get a vein in. So then there are other things that emergency medical providers actually can do. So I would say that in the situation where a hospital where they're just not equipped, and again, thinking about the state hospital, that the emergency medical providers probably better skilled at handling an emergency situation.
I guess about to answer, the question is this the kind of language that you used in other states, or do we need to have something that speaks to exactly that point, that you're obligated to transfer, but it's got to be, you know, the right way and the right transfer. It's not just anybody can send somebody out by an ambulance. There is an obligation to try and make sure the person can get there, can survive and get there.
Yeah, our goal is that at the urgent care center, they are better attuned to look for sepsis, which can cascade very, very quickly. Mortality can go up between 5% and 9% every hour that treatment is delayed. So if an ambulance is required, they should call an ambulance. And in fact, half of sepsis patients travel in an ambulance to hospitals. And so those crews are getting better and better equipped to understand what they need to do in transit, what to communicate into the emergency department so that they know they have someone in medical emergency coming through the doors. And this is not someone who can wait in the emergency room for 4 or 8 hours.
Okay, so Delegate Hurd, does that training, is that assumed that the EMTs also have that training, or is this so special that they need to be included in the training cohort too?
The bill doesn't address EMTs. The bill addresses where the sepsis would be identified, either in the hospital or the urgent care facility. That by the time the EMTs are involved, as Mr. Hammond said, they would be better equipped, and they're becoming more and more attuned to identifying and treating sepsis. But they're not included in the bill.
And we do provide education and training for EMS professionals, and we provide that training for about 300,000 now nationally. So we have training materials in place, but it's not part of the bill.
And may I add?
With your indulgence, Madam Chair?
I'd like to know what the doctor how the doctor wants to follow up on that.
Thank you. Go ahead.
Oh, thank you. And I wanted to add that in response to your question, you were asking about, do other states have language in their statutes about the transfer? And the other states don't, that you're aware of, the other states haven't included urgent cares. They were focused on the hospitals. So this is actually novel ground. And so I appreciate your bringing up the potential for transfer, because we know in other situations in the past, there has been a concern about dumping or putting people in an ambulance where they are not stabilized. So I appreciate your attention to that.
Right, seeing no further questions, thank you all very much. Thank you so much for your patience and waiting with us today. We appreciate your time and your testimony. I am gonna call Beckine Townsend up as the last clean favorable person. We're interested in hearing what MHA has to say on this. Thank you for that.
The importance of awareness and education, because as the previous panel said, things can go south very, very quickly, and you really need to get to the right place. So we are in support of this bill. We may have a friendly concept, and that is, instead of having each individual hospital develop their own protocols, link it to the CMS protocols. That way, everybody's uniform in the state. And as science evolves and as evidence-based research comes up with different things, you don't have to come back into the statute to amend it. And that way we're current on the current thinking.
Okay.
So that's what we have.
That's your testimony. We love that testimony. Thank you.
It's a bad problem. It's really serious.
Questions from Ms. Beguine? I do have one. Will you please work with the sponsor to talk about that as a potential amendment?
There's a group of us that
will
absolutely work with the sponsor.
All right, thank you. Seeing no questions, I want to go to a friendly with amendment or favorable with amendment, and that's Jennifer Whitten and Brian Monrose and Dana Kaufman. Welcome back.
Thank you. I guess I'll go
You wanna go
first.
first?
Thank you, Madam Chair and committee members. It's a pleasure to be here before you today. Jennifer Whitten here, representing LifeBridge Health. And I just want to take a moment to thank the family and the advocates who've been working on this and the delegate for bringing this issue to us today. Under unfortunate circumstances, but appreciate the opportunity. So here with LifeBridge Health, I'm in a unique position in that we have 3 acute care hospitals, 1 freestanding medical facility, and we actually have a number of urgent care centers across the state. And we do believe this is a very important issue. In fact, CMS has a number of guidance and requirements for hospitals to report and to have a number of protocols. I believe you'll hear from my colleague, Dana Kaufman, in terms of just some friendly amendments that the delegate has considered. I think really our position here is the protocols and the guidelines on treating sepsis does evolve because it is so dynamic and so comprehensive. In fact, the American College of Emergency Physicians and CMS proposed new guidelines just last year. So as this body knows, when we start putting very specific prescriptive standards in statutory requirements, that causes a bit of a challenge when we're trying to evolve with some of the national guidelines for care. So simply all we're asking is that we come up with some language so that we're making sure we're adhering to those guidelines as they evolve. And I think we fundamentally across the board are very supportive of additional training and that early assessment so we can identify this. And it is a very tricky because of the source of origin. It may not always be as clear when it presents to the clinician. And so doing that due diligence, both on the provider side and also with the public, I think is really important. So continuing that sepsis campaign would be key. So with full respect, we thank for the consideration and working with the delegate on these amendments. And thank you for taking this issue up.
Thank you. Mr. Monroe, Monrose.
Good afternoon, Vice Chair and members of the committee. For the record, my name is Brian Morose. I'm the Deputy Secretary of the MDH Healthcare System and Operations for the Maryland Department of Health. As the Deputy Secretary of the Healthcare System, I oversee 11 healthcare facilities. 7 of those are special hospitals. I think we've answered a lot of my testimony by the questions that were coming up in the amendment, so I'm going to cut it very short. We do support this bill with the amendments. The special hospitals that we oversee are really not equipped to treat and manage patients with sepsis, but we do identify that this is a crucial issue that really needs support as we go through this. So we worked with the sponsors and really would like to emphasize the amendments, which would require special hospitals and urgent cares to develop protocols to focus on early screening and detection of sepsis and require septic patients to be transferred to a hospital that can provide that appropriate level of care. We will also support to implement periodic training for specified staff and update staff on any changes and implement those quality measures. So overall, we support this bill. And again, we've talked about the amendments. So thank you.
Thank you very much. Ms. Kaufman.
Thank you very much, Madam Vice Chair, members of the committee. For the record, I'm Dana Kaufman. I'm here on behalf of Patient First. They operate about 23 or 24 urgent care centers in the state of Maryland. We met with Delegate Kerr last week, and the amendments put forth by the sponsor are supported by Patient First. We appreciate the acknowledgement that urgent care centers ultimately are not hospitals, and we do not have the same resources and tools available to us to treat. However, the need to have protocols and, more importantly, training on those protocols, we strongly support. Again, we appreciate the amendments put forward by Delegate Kerr and the recognition of our limitations. So with that, I would say thank you, and any questions.
Thank you. Are there questions for this panel? Nothing to my right, no, nothing to my left. I do have one question. Ms. Whitten, you were referring, I think, to the protocol. Were you speaking to the same protocol that Ms. Townsend was speaking to in terms of using the CMS protocol to sort of sync all the information across the hospitals and urgent care centers?
Exactly, Madam Chair. So CMS has a protocol. I believe it's called Sepsis Pathway 1. I could be a little off, but it's something to that regard and has a number of protocols and measurements that are required. And then also the American College of Emergency Physicians has a number of guidance too. And I think they correlate those together. So maybe we could think about, I know we've worked on a number of bills here in this committee that we've had some language that we can capture to make sure we're getting the right protocols that we're referring to, but they pretty much line up with what's currently in the bill, but this would allow us just some flexibility.
Okay, great. Thank you. All right, seeing no questions, then that completes the hearing on House Bill 84. Thank you all very much for your time and your testimony today. And we will move to the last bill of the day, which is House Bill 865. And that's Maryland Medical Assistance Program and Health Insurance coverage for orthosis and prosthesis. And Delegate Martinez, would you bring your? Oh, I'm sorry. We're going to stop by. I've just been corrected. There were actually 2 more witnesses on this last bill. So, Delegate Martinez, I apologize. And that's so, thank you very much for pointing that out. So we have Emily Tarsel and John Kelly in the audience. And this is an unfavorable panel. Is Emily Tarsel still here? I guess, Mr. Kelly, I think you're it. And I sincerely apologize that I did not call your name.
Yes, I just very thinking moment there after. But good afternoon. My name is John Kelly. Thank you for giving this opportunity. First, I want to make clear I do not oppose healthcare facilities having protocols for treating sepsis. What I oppose is language in the bill that is likely to restrict the use of safe and effective sepsis treatments. The bill conflates evidence-based protocols with generally acceptable standards of care. It implies that if protocols are evidence-based, and only if they're evidence-based, they're regarded as generally accepted standards of care. However, there are evidence-based protocols that have not found their way into the generally accepted category. This is not just merely a matter of semantics. For example, Eastern Virginia Medical School uses a sepsis protocol that is effective but not yet considered generally accepted. In one clinical trial using its protocol, it treated 150 patients with severe sepsis and sepsis shock, and only one patient died from sepsis itself. This mortality rate of less than 1% is far better than the 30 to 50% rates reported for standard protocols. HB 84 would likely preclude or introduce a strong bias against the use of protocols like the schools. This raises important questions about current sepsis protocols themselves and about the need to expand and require them. Is the problem of sepsis deaths that healthcare facilities are not currently using or not following current protocols, or is it the current protocols are not as effective as desired or believed? In the spirit of the bill's concern for evidence-based requirements, the committee should have answers to these questions before considering legislation requiring sepsis protocols. Thank you.
Thank you very much, Mr. Kelly. Are there questions for this witness? I have a question, sir.
Yes.
Are you familiar with the CMS protocol or have any thoughts on that particular tool?
No, I'm not with the specifics of it, but I know it does not include protocols like the one at Eastern Virginia Medical School and protocols like that. And so my concern is with what's regarded as generally accepted and how quickly safe and effective protocols that are out there that may have not found their way into the CMS or to locally generally accepted principles that doctors would not be able to make judgments to use those protocols, or they would feel intimidated in some way about using them.
Okay, thank you. Seeing no further questions, I apologize again and thank you very much for your patience. And that does conclude the hearing on House Bill 84. And we will move to House Bill 865. Delegate Martinez, you can go back up again. And Delegate Martinez, I think you have Patrick Enright, Farhad Astavari, John Edward Heath, Nathan Sim.
Okay.
Is there anyone else that you'd like me to call up with your panel?
Well, good. If you need to pull up a chair, just pull up.
Yeah, just pull up a chair.
Well, while we get the chair pulled up, I will start my testimony.
Thank you, Delegate.
Good evening, Madam Chair, colleagues. For the record, I'm Delegate Ashanti Martinez, here to present House Bill 865, the Maryland Medical Assistance Program and Health Insurance Coverage for orthoses and prostheses. This bill would require both private payers in the Maryland Medical Assistance Program to provide access to prostheses and orthoses for physical activity. Currently, individuals living with limb loss and limb difference in the state of Maryland can only access a singular device per limb intended for the use of all activities, although the devices cannot safely do all activities. In order to be physically active and participate in activities such as running, biking, swimming, weightlifting, and other activities like Orange Theory, which I love, individuals would need to have an appropriately designed activity-specific prosthesis and custom orthotics device. Insurance companies consider these devices as not medically necessary and therefore routinely deny the secondary device needed for individuals of all ages to live healthy and active lifestyles. HB 865 would ensure individuals with disabilities can access activity-specific prostheses and orthoses to experience the benefits of physical activity in the manner as their non-disabled neighbors. According to the Amputee Coalition and the Shirley Ryan Abilities Lab, combined estimate of 4.7 million people in America with limb loss or limb difference, there is an estimated 87,000 Marylanders with limb loss, limb difference, or mobility impairments who are unable to access life-changing orthotics or prosthetics, OMP care, due to the lack of coverage and affordability, leaving them unable to fulfill and participate fully in society. Without the appropriate health coverage, adults, children, and families are forced to incur prohibitive out-of-pocket costs, risk harm or injury using an inappropriate device, or live without the benefits of appropriate OMP care, leading to sedentary lifestyles with costly secondary health complications and cost. Today, one of the biggest health concerns in the country is physical inactivity. Due to the lack of access to coverage, many people who have disabilities do not have a choice. According to the CDC, 50% of adults with disabilities don't participate in aerobic activity. This not only increases the risk of obesity and a sedentary lifestyle, but causes negative mental health risk. Without equitable access to appropriately designed athletic-specific prosthetics and custom orthotic devices, trying to meet the HHS physical activity guidelines is not only impossible, but also dangerous and harmful when utilizing an inadequate device. The consequences of a sedentary lifestyle are not confined to negative health outcomes for the individual, but a lack of physical activity also causes a severe systemic strain on our nation's healthcare economy. A more active, healthier number of people with limb loss and limb difference in Maryland would lead to higher rates of employment, advancement in their careers, and have improved physical and mental health. So today, we not only have the opportunity to work towards addressing the public health challenges, we have the opportunity to create equity and access to OMP care, to participate in activities that provide Marylanders with limb loss and limb difference a fulfilling life. And I urge the committee to have a favorable review of House Bill 865.
Thank you, Delegate. Who would you like to go next?
Good afternoon, Madam Chair, members of the committee. My name is John Edward Heath. I am a T64 Paralympic sprinter, 100 and 200 meters for Team USA. I'm also a lower extremity adaptive CrossFit athlete, and I'm also a Paralympic snowboarder. However, I am a Marine Corps Staff Sergeant retired, and most importantly, I am an Annapolitan. For those who don't know, that means I'm from Annapolis. That being said, if you would have asked me at 17 years old that I was going to become an amputee at the age of 30, I would have laughed, because that's not what we all think and intend. As a veteran, a lot of individuals assume that I stepped on a bomb. However, that's not what happened. I got into an accident, had 13 lower extremity salvation surgeries. And during the Tokyo Olympics, as an Olympic weightlifter, I had to make a decision to get an amputation or go into Tokyo trials with a 50% leg. Used to use an orthotics called the IDEO Exosim. This orthotics was created for service members to get back into service after injury with salvaged limb. That being said, now that I am competing at the highest level, my purpose and my mission was regained because one of the few things that the VA has gotten correctly has understood putting the cost up front over long-term longevity of mental health and everything else. If I would not have had, this all occurred during COVID. This also occurred when I lost my partner to suicide. This also occurred when I had to give up my job as a coach at the United States Naval Academy. That being said, we have a lot of our youth and new amputees in this world that are, the numbers are increasing. We need to give them a sense of purpose. You're telling them that they cannot regain something as simple as running. And everyone assumes that what we're asking for is something as extreme as the Paralympics. I leave you with this. God forbid one of you guys get into an accident or someone in your family becomes an amputee and we don't have this in place. A lot of you guys have hobbies. A lot of you guys do extracurricular activities. Imagine if tomorrow you wake up and you're not able to do that because you don't have the appropriate prosthetics. Thank you again.
Thank you. Thank you for your service
Thank you.
as a coach. And who's next? This gentleman here.
Good afternoon. My name is Nathan Sim. I'm 11 years old and I live in Ocean City, Maryland, and I'm an amputee. I was born with fibular hemimelia and had my amputation at 1 year old. I played travel baseball and love to also swim and played soccer this winter. I currently have a Cheetah Explorer leg and I was given it by the Challenged Athletes Foundation. I'm running faster and even scored double in my school endurance tests for running since having it. I was half as fast running in my everyday leg as I am in this Cheetah leg, which helps me with my sports. I can feel the difference. Please pass this bill. Thank you.
Thank you. Thank you, Nathan. Thank you for being here. And congratulations to you. As you can see, the committee is very proud of you. Who would like to go next?
Good afternoon, ladies and gentlemen. My name is Farhad Astavari. I have a doctorate degree in physical therapy. I'm a clinical director for amputee care and prosthetic services with Adventist Healthcare Rehabilitation. I've been exclusively working with amputee patients in the last 15 years and working with patients from 2 amputation to hemipelvectomy that puts me in this spot to just come in favor of this bill. We have about 507 amputations in the US every day. We have 185,000 amputation every year, and we have over 5 million amputations in the US at this point. So just to put a perspective to this, that all of us every day, we wear different shoes. If I look at around the room here and tell you guys that, you know, you have to wear high heels every day for the activities that you want to do, it's impossible. So when some of these patients are ending up having issues, ending up like a skin breakdown and having pain, low back discomfort and things like that, that is going to come back. And they are like patients that are coming every day. They're coming for different reasons and they have issues that we have to tackle. So to me, it's just a no-brainer that, you know, like giving a patient something to run. We don't just do activities just standing or walking. We do activities like Nate was talking about, like running. Like Shannon is gonna tell you the activities that she does outside of work, you know, when she goes to the gym or something. They need something to work with. And it's kind of like shortcoming on the insurance companies and whatnot to not allow the patients to get what they need. And they end up with early osteoporosis, osteopenia. They end up with a skin breakdown. They end up with falls. I have patients right now that are waiting for almost a year or so to get the prosthetic that they need. 19-year-old that she has an entire life ahead of her, but because of the insurance company, she's not able to get what she wants. I have a 65-year-old.
Finish your thought, please.
I have a 65-year-old patient right now that is trying to get a microprocessor need, and need that she's going to need to go back to her life, go back and work as a as a psychologist, but she's not able to do that. And she has multiple falls and she has issues. And even though the judge ordered the insurance company that they need to give the patient what they need, they are still fighting us. They're still refusing to do so.
Thank you very much. And who's next there?
Yep.
There we go. Thanks.
Hold on a second.
Good afternoon. My name's Shanna Dillingham, and I'm here today asking for your vote in favor of House Bill 865. In 1989, at the age of 17, I contracted a rare bacterial infection called fulminant meningococcemia. This disease develops rapidly and is extremely severe, and in my case, left me as a left leg below the knee amputee, a right foot transmetatarsal amputee, significant kidney impairment, and extensive scarring over 50% of my body. At the time I got sick, I was in junior high school. I was a junior in high school, running track on the POM squad, involved in student government, and training to get my lifeguarding certificate in hopes to be a beach guard during the summers. My life came to a halt. I spent the next 3 months at Children's National Hospital in DC fighting for my life, and then an additional 3 months at the Alfred I. DuPont Institute for Children in Delaware in rehab. This is where the real work began. And my world of prosthetics became my new normal, my lifeline, my independence. I relearned how to walk using a prosthesis. And from there, I went on to finish high school, college, and graduate school. And although those are great accomplishments, I never did make it to that lifeguard stand. The beach has always been my place of peace and tranquility. And I have continued to go, but the experience is very different. My choice of leg to wear to the beach has either been my everyday leg, which the salt water and sand together deteriorate the components, or an old prosthesis which doesn't fit properly and can ultimately lead to skin breakdown, which is painful and makes it difficult to walk. What was once my place of refuge has now become an annoyance. There are prosthetic legs out there designed to withstand the salt water and sand, but they are not appropriate for me to wear for daily use. My insurance doesn't cover this kind of leg for me because it is deemed medically unnecessary, and I can't afford to pay for it on my own. My solution has been to wear my everyday leg and deal with the consequences, but I shouldn't have to do that. With your support, you will be allowing individuals like me and those of us in the amputee community to live the active life we wish. I urge you to support House Bill 865. Thank you.
Thank you. Want to trade seats?
Madam Vice Chair and Committee, my name is Cheryl Sachs, and I thank you for the opportunity to comment in favor of HB 865. I am a clinician, and if I wasn't seeing before you today, I would be seeing my patients. But I'm going to take this time to address two fiscal and social impact reports on this legislation. First, the fiscal note completed by DLS, specifically focusing on Medicaid, and the second, the PMPM report submitted with the written testimony focusing on commercial plans. I'd first like to address the grossly inflated fiscal note for this bill. On the top of page 6, it is written, the Department of Legislative Services notes that these figures include all DME, DMS claims, not just those for orthoses and prostheses. This means that the fiscal note is basing its estimate of the cost of this legislation on the state by looking at all DME claims, which includes wheelchairs, patient lifts, hospital beds, and CPAP machines, just to name a few. The CMS fee schedule includes 3,358 codes, only 847 of which are orthotic and prosthetic billing codes, roughly 21%. Without any comment on the utilization element of their calculation, this fiscal impact report's inflated data is as if you wanted to know how much money you were going to spend on fruits and vegetables, and you were given a forecast budget. But the budget that you were provided actually calculated every single grocery item you purchased, including beauty products and medication, not a budget just for fruits and vegetables. I would like to emphasize that while this legislation does involve a cost increase, it is pennies spent towards an already marginalized community, including children who are being put at a lifetime of disadvantage from a physical, social, and mental health equity standpoint. An independent contractor was hired to research the fiscal and social impact of this legislation on commercial payers, and her valid peer-reviewed methodology and research showed that the estimated PMPM would conservatively range from 1 to 25 cents. This research has been used to pass legislation in Colorado, Illinois, and New Mexico, and is currently being reviewed in 8 additional states who have introduced legislation similar to ours. It's very important to mention the cost benefits and savings of this legislation too. By providing patients with activity-specific orthotic and prosthetic devices, the risk of injury and development of comorbidities such as cardiovascular disease, cancer, hypertension, and depression, all associated with a sedentary lifestyle, decrease significantly. And the research has shown that this could potentially save the state over $100 million each year. This cannot and will not happen without this legislation. It is important to note that such devices will only be provided when medically necessary, meaning that not every single person with limb loss, limb difference, or mobility impairments in the state would qualify for a secondary device under the proposed legislation. Between the cost savings, health benefits, and the amazing stories that you've heard and will continue to hear today, passing this legislation just makes sense, and I thank you sincerely for your time and consideration.
Thank you for your testimony, and thank you for taking time out of work. I was coming in when I heard your testimony. Really
you, Chair.
appreciate
Chair
it. And who do we have here? I know. What's his name? Nathan?
My name is Nathan Sim.
Hi, Nathan. It's great to meet you. I had not met you, so I wanted to acknowledge you. Delegate Kaiser.
Thank you, Madam Chair. You missed his excellent testimony.
I have to look at the video. I will.
Delegate Martinez, I was going to ask you a question about the fiscal note, but the last person testifying addressed a lot of the issues. So I still want to stay on that point and ask if you have talked to the fiscal note writers, since they seemingly included several services that you weren't intending to be covered by your bill.
Yeah, no, thank you for the question. I have not spoken to them as of yet. I know my office is working on getting meetings with not only them, but also with the department. If you look in the group of letters, the department sent information letter. We're thankful. And so we're talking with them around the bill as well.
Thank you. I have Delegate Hutchinson, followed by Taveras, followed by Vice Chair Collison.
Thank you, Madam Chair. I
You're
just
welcome.
need a little bit of help. And this is to the doctor. Did you say that in testimony is a fiscal note for what it would cost the private payers in here? And do you know where that is?
Yes, I believe so. So, my understanding was that there was, and I do have a copy of the report. If it's something that can be provided to the committee afterwards, we'd be happy to do so. I was under the impression that it was submitted, with the testimony prior to the hearing. But again, I would be happy to provide this to the committee, for further review.
That would be great.
Yeah,
if you could do
absolutely.
that. Thank you. Delegate Taveras.
Thank you, Madam Chair.
Welcome.
I want to say, while I heard everybody's testimony in the back and I had to run over here. And I want to say I was so impressed with everyone's story. Thank you for your service. My question is that, are we calculating the cost benefit, or rather the medical benefits to being able to provide these improved prostheses, in terms of improved health outcomes?
So again, just a caveat. So I am not a researcher. My background is I'm a certified prosthetics and orthotics practitioner. So I've been diving in and talking to the researcher a little bit about this, but yes. So when someone with a prosthesis or orthosis is doing something beyond kind of daily ambulation, if we're looking at lower extremity, or also this bill does address any upper extremity issues as well, for example. So if someone has an arm amputation, there are a lot of things that the human body needs to be able to do that you can't do when you don't have all of your limbs functioning the way that they were designed to. So there's a lot of compensation, and Farhad can probably speak to that as well, but you're seeing a lot of individuals at even lower activities and even with elite athletes who are having issues with back pain. They're having chronic pain throughout their bodies, issues with their hips, issues with their sound limbs. A lot of our upper extremity patients are dealing with back issues with their shoulders and range of motion. So what we're finding is that for individuals like Nathan, who are able to receive activity-specific orthoses and prostheses through charities, or through donation or through companies kind of eating the cost, they're not experiencing such significant physical barriers. And then also just the psychological and mental health component of this legislation, when you're able to participate within your community, when you're able to spend time with your peers, that has implications, again, well beyond just your whole body physical needs. Thank you for your question.
Thank you. Vice Chair Collison.
Thank you, Madam Chair. May I have two questions?
Oh, Gil is not here. You can have them.
So my first question, I think, Ms. Sachs, you're probably in the best position to answer this.
Okay.
Can you explain the difference between an orthosis and a prosthesis?
Absolutely, I'd be happy to do that. So when the bill language is discussing prostheses, we're specifically talking about artificial arms and artificial legs. Obviously, there are different types of internal prostheses, such as if someone needs like a total hip replacement, but we are specifically talking about artificial arms and artificial legs. Orthoses are external devices that support segments of the body, whether that's a leg or an arm or a back. So that's kind of the differentiation between those two. Prostheses are replacing something that's missing, and orthoses are just supporting and correcting something that is still there.
So like a special brace or something might be an orthosis?
Yes, ma'am.
Orthoses? Okay,
Mhm.
great. So my second question is for Mr. Sims. So you've been here a few hours, I think. I was just wondering if you had any thoughts about the process and what it's been like listening to folks tell their stories and listening to us ask questions. Any thoughts?
And it's interesting.
Well, we really appreciate you coming and telling your story, Nathan. You were, as Delegate Kaiser said, a great witness, so thank you.
I didn't see any other witnesses. Oh, I do. Delegate Gazzoni, go ahead.
Hiding down here at the end. Thank you, Madam Chair. This is, this may be in the report that you shared, which is in the committee testimony. But you mentioned that there are other states. So I was curious about, this goes back to the fiscal note question. Is there data from other states that sort of really refutes based on their experience that they've had, like Colorado? I don't know how long the states have had this.
Yeah, so
it sort of
that's-
says, hey, here's what the more fiscal note is going to look like.
So that's a really good question. And so the short answer is no. So this bill is part of a grassroots initiative across the country where advocates in different states who are part of this community are introducing legislation that is going to provide them access to this care. We actually just found out, so again, there are 5 states that have passed similar legislation. One of them is New Mexico, and they actually just had their first patient receive her activity-specific device. And in this case, it was a running leg. So the first state to pass the law was Maine, and I believe they passed it in 22, but it wasn't going to go into effect for a few years after. So we don't know. But that's part of the reason that I believe the end of this bill language does have a reporting element to it to make sure that we can really capture what is happening should this legislation be passed. Thank you.
Thank you.
for your
I don't
question.
see any other questions, and I do want to say that there is. Oh, Deli Lewis, did you do it later? You did, because I did not see
It was a
that.
test. It was a test.
It was a test. I don't have 2020, but now I see it. Go ahead.
Thank you so much, Madam Chair. Thank you, Delegate Martinez, for this really thoughtful and important bill. I'm curious, the young lady who spoke about missing being on the beach. Yeah, this question's for you.
Shannon, come grab a seat.
And you referred to how important access to that setting is for the fullness of your life and your mental well-being. And so I really appreciated your remarks about that. I'm curious, when it comes to having a prosthetic limb, is it actually necessary to have multiple different limbs for different uses, different settings, like you might have different shoes for different, events?
I appreciate the question. So I just want you to think about the beach and sand and how sand gets in everything. So if I were to not wear anything into the water, I would not be able to put my leg back on with a liner with all the sand. I would have to have some sort of fresh water at the beach's edge. A lot of amputees won't even go to the beach for that reason. I do, and just suffer the consequences. So yes, it would be beneficial because when I wear my everyday walking leg, eventually that will deteriorate from the salt water and sand, and then I have to get another new walking leg, which would be approved. So it's not cost effective to just keep getting my new everyday leg every 2 years or 3 years when I could just have a leg just for the beach, which would be used just for the beach and swimming in the ocean.
Yes.
So prosthetic limbs, like anything, wear out. They have to be replaced. So there's a normal lifespan for the normal use of that limb.
Correct.
So what you call your everyday leg, it's for walking around and doing your everyday life.
Correct.
But a separate special limb with special materials and construction that could withstand. Okay, so I just want to make sure I understand this. A person with a prosthetic limb or an orthosis might need more than one such, support. So would this bill help to pay for those different types of support. So you need, like, you need dangly earrings and you need studs, you need both, right? So you need a beach prosthesis and you need a rock, you need two, and this
Well,
will help
really,
pay
it
for
would be
those.
a swimming
So
leg.
But you need at least two, and this bill would help pay for that.
Correct.
Okay, I'm so glad to hear that. Thank you, thank you.
Madam Chair, may I add to that, please?
Is there a follow-up?
Would you like to have a seat and maybe the delegate has a follow-up question? And because yesterday was Valentine's, I'm gonna allow it.
Oh,
Go
fantastic.
ahead.
I'm opposed to Valentine's Day. I think I should get an extra question.
I think you should just take it and not say anything.
We take it.
There's a reason why they say less is best. Go ahead.
Overrated. So I wonder if anyone else had a more insight, could share some follow-up on that.
Madam Delegate, I would love the opportunity. So, one of the things that we are fortunate of in Maryland is that there is already a parity law in place, which requires insurance companies to pay for baseline prostheses for everyday use. That is not true across the country. We are one of 21 states. So this is actually building upon the existing legislation and recognizing that, as Farhad kind of alluded to, there's not one prosthetic arm or prosthetic leg that can do all the activities that an able-bodied person can do with their limbs. So I just wanted to add that. And also, kind of as Shannon was alluding to, having a swim leg or a waterproof prosthesis costs either the same amount or actually less than her everyday prosthesis. So these secondary prostheses and orthoses are not necessarily going to cost more than the everyday devices. In fact, in some instances, so for an active above knee amputee user, or for someone who has a microprocessor hand, their everyday prostheses are probably going to cost at least double what is activity specific device would cost.
You're
you.
welcome. Anyone else? Delegate Johnson.
Thank you, Madam Chair. And since you sat back down, I'm gonna throw a question out.
I'll do my best.
So how many different types of prosthesis are there for like different activities? And in this bill, what would be the limit of how many you could get?
Thank you, Delegate, for your question. It's a really good question. So the short answer would be endless. So when we are building these custom devices for patients, they're made up of different components. So there's something called a socket, and that is what, for prostheses, that's what fits over the residual limb. So what is left of the patient's arm or leg, that's something that is custom made to fit their limb. Then depending on the level of amputation, there's either a prosthetic elbow or a prosthetic hand, knee, or foot. So there are hundreds of different prosthetic feet on the market. So it's my job to work with my patients, work with their physicians, their physical therapists, to figure out what type of foot or hand is going to be most appropriate to meet their everyday needs. It then becomes what are the patient's goals, right? So again, not everyone is necessarily going to benefit from an activity specific prosthesis. I had a patient who was 97 years old, and we fit her with she was a bilateral amputee, so she didn't have either legs, and fitting her with prostheses helped her to live another 7 years because she was able to get up and walk. For her, having activity-specific prosthetic legs would not have been medically necessary because her baseline devices accomplished that goal. Not everyone's going to want to go to the beach or need a swim leg. So again, the legislation, this is not something asking for endless devices. There's language in the bill that really is centered on medical necessity. But when it comes to the construction of these custom orthoses and prostheses, there isn't a finite number just because of the customization associated with it. Thank you.
You're welcome. Any other questions? I just want to say thank you all for coming. Really appreciate it. We have more witnesses that I'm going to call. But Delegate Martinez, you saw the letter from the department, correct?
Yes, and we are going to meet to talk some more around some of the ideas that they have on potential amendments. But as the witnesses spoke to, I think a lot of the cost concerns are a little inflated, and I think we can have more discussions with them around what the actual cost of this bill would be.
So, and you know, there's a lot of support, right? I would say probably everyone wants to pass it. But the fiscal note, because we are in a year where we have to be very careful, it's one that creates a little bit of a challenge. And I usually don't do this, but I'm being very honest. But it's not that it cannot be worked out, right? And you have an amazing sponsor, so I know he's going to meet with the department and the industry and see if something can be done, right?
Absolutely.
As well. I want to thank you for coming, and I must say, Nathan, you know, that everybody loves you, and thank you for coming. It makes a difference, okay? You have a blessed day. I'm gonna call the rest of the people. There's a Shannon Sim. She's not here?
No.
Oh, you're here? Did you testify? Not yet? Okay. Okay, you can come up. And then also, if I may have, Mr. Potts, Nina Bondre, Thomas Peter, if you can come up and just pull a chair. Okay, the other ones are, can you pull the virtual ones? There's actually 4 of them. Just pull them up, please. Meanwhile, I like to see Shannon. I like to see Colin and Nina. I mean, and Colin, that would be great. How are you? Thank you for being patient, okay? And you can get started. Whoever wants to start.
Do you want to go?
You go ahead.
Okay. Okay. Good afternoon.
Good afternoon.
I am Shannon Sim, the proud mother of the young man you just heard talk.
Well, he did beautifully. He
Thank
reflects
you.
you beautifully.
He's a good boy. Nathan was born with fibular hemimelia, as he said, which was the fibula bone missing, and he had a shortened bowed tibia with 2 toes, which they amputated in order for him to be able to get fit with a prosthesis so he could run and play like all the other kids that he will be growing up with.
Okay.
Nathan is very rough and tumble. We've had many repairs to legs. I was just telling the story. He had a foot fly off. It went that way. He went that way. He was 4 years old. He didn't care, but it's been a process. As he's gotten older, he's gotten into sports, especially like he mentioned, travel baseball. What we've noticed is that there are certain things that he can do better in the leg he has been given to from the Challenged Athletes Foundation as he's playing sports. We need to protect his muscles, his tendons, his flexibility, and making sure that he has the proper leg to do that. When he was born, I promised him, I will never tell you, no, you can't do that because you don't have the right leg for that. I told him that when he was born. And I'm still going to tell my child that to this day. I'm not going to tell him you can't play baseball because you have the wrong leg to play in. I will not do that. The leg that he was given, he's going to outgrow it. What are we going to do? What are we going to replace it with? I don't want him to get hurt as he's playing baseball. I want him to continue to thrive. He has a dream of going to the MLB, and I'm going to keep on pushing him that he can do that, but he needs the proper prosthetic leg to do that. And he's still growing, and he's going to keep on growing. He can't play in his everyday leg. That's going to hurt him. He needs a leg that is made properly for him to continue playing baseball and running around with his friends and all the other kids, because I'm not going to tell him no.
Thank you. And thank you for sharing your story and for being here. We really appreciate it, okay? Next, please.
Hello. I hope
Good
you all are
afternoon.
doing well. I'm the youngest of 8 kids, so I'm finishing up last on this, and this is a very familiar spot for me. Thank you guys for your patience and a little bit of energy. I know it's the end of the day, so thank you for listening and being a part of this. So my name is Colin Potts. I'm the Chief Operating Officer of Regenerative Orthopedics and Sports Medicine. My journey started in 2000. I had an accident, and then over the next 17 years had 20 surgeries, and then the 21st was an amputation of my leg. I was up at HSS in New York for the last 5. They're in the limb saving business, and then all of a sudden you wake up on the 21st surgery and you don't have a leg. And so the battle begins in the journey of everyone telling you you're a failure. Everyone's telling you you'll never walk again. Everyone's telling you that your life is going to forever change. So I took that negative energy, and you get going in the process, and you get a foot and you start the process. And all of a sudden I'm like, I can't even go down the sidewalk without tripping because the foot doesn't move. The prosthesis doesn't move. I can't go off a sidewalk. It doesn't move. So all of a sudden, all my positive energy it took to get through this, I was hitting the barrier of a foot and what I was provided with, because you're over 50, they're like, oh, he's not going to be active. Why is he going to be active? He's not going to run. Give him the basic foot. So through that, we fought through that. And all of a sudden, you know, I was moving quickly in physical therapy, thanks to the people here. And all of a sudden I was like, I want to do more. And I was going to fight to get my life back. I had sat for all those surgeries and 17 years of pain. I was going to fight every day, one more step to get my life back. So long and short is that all of a sudden, you know, I wanted to run. And they're like, well, if you want to run and insurance doesn't pay for that, that's $17,000 to $20,000. That's an expensive pair of shoes, right? I mean, in terms of that. So being able to battle through and do that and keep going in my world, in 1 year after I got my first prosthesis, I was walking, running, swimming, and ran a 5K. And our goal today is to get accessibility for people, not only to exist, but to get out in their world and thrive. But can we just get people back to the place where they dare to dream, to do the activities that we all do and you all do every day? Thank you.
And thank you. And I want to thank you for sharing your story and for being here today. You know, it takes a lot to get here, right? Find
Right.
parking, come through security. And I know it's a challenge. So I just want to thank you for coming, okay?
I appreciate that.
You're most welcome. We have Patrick Enright. I hope I pronounced your last name correctly. And if I didn't, feel free to correct me.
Good afternoon, Madam Chair, delegates of the committee. My name is Patrick Enright. I live in Gambrills. Today is the day the Baltimore Orioles pitchers and catchers report for spring training. So allow me to share with you quickly a story about baseball, a young boy, and a prosthetic leg. And that young boy is my grandson, Nathan, who you just heard from before. Last summer, I had the honor of watching him play in a playoff game in his travel Little League team. And at one point, he hit the ball, got on first base. The fellow behind him hit the ball further, and Nathan's heading for home. He got to third base and saw that the coach at home plate was giving him the slide sign because the fielder was about to throw and cut him off at home plate. Nathan executed a textbook perfect smooth slide right across home plate under the throw, beat the tag, and scored the run.
Go, Nathan.
So let me tell you about this bill. This bill, I believe, will allay working parents' fears about out-of-pocket expenses to obtain everyday legs so children like Nathan can go to school and live life and grow up, and also to have insurance so that they can continue to provide even specialty legs for their children so they can grow up to be productive Marylanders, have their own life's games that they will play in life, and cross their own personal home plates and score their own personal runs on their own 2 feet. Please pass this bill out of committee to the floor and hopefully on to the governor. Thank you very much for your kind attention.
Thank you for being here. And I'm sure Delegate Rosenberg really appreciated your remarks. And he's going to tell you why in a minute. But go ahead, Delegate Rosenberg.
Thank you, Madam Chair. Well, as I was going to say, since yesterday today is the first day of spring training, can I be allowed to ask a question of this witness's grandson, which
Yes.
I was late on the ball?
Yeah.
What position do you play? And who's your favorite major league ball player?
Oh boy.
I play first base and I pitch, and my favorite MLB player is Adley Rutschman, the catcher for the Orioles.
There you go.
Thank you.
There you go. Nathan, you are loved. Are there any questions? Yes, Delegate Hutchinson.
You, Madam
You're
Chair.
welcome.
I haven't been here for a long time. This is only my second year. Next to Nathan's testimony, that was the coolest testimony I've seen since being here in HGO. That was really passionate and showed your love for Nathan and this bill. And it clearly, I knew, woke up Delegate Rosenberg to pay attention as well.
Good job, Pop.
Thank you.
If you have not gotten it yet, Delegate Rosenberg loves the Orioles. Anyway, I just want to say thank you so much. Oh, I have one more? Oh, yes, Delegate Chisholm.
I do like when you.
You were late?
I love when you pay attention to the right, but no, I went up with Rosenberg, you know, when baseball gets talked about. I just want to say something to Nathan. First of all, you're very inspirational and, you know, your attitude is going to take you a long way in life. And this isn't exactly the same, but in Major League Baseball, when you were speaking, I was thinking about it. There was a guy named Jim Abbott that played for the California Angels for 10 years. He was an amazing guy. Didn't really have a prosthetic, but he was missing most of his left. No, he was a left-handed pitcher. Yeah, so he's right. And yeah, so you've seen him play. So he's a guy that is much like you. He's not going to take no for an answer. You obviously have parents and grandparents around you that aren't going to take no for an answer. All you got to do is keep moving forward. So God bless you for that, buddy. And I can't wait to watch in the major leagues.
So I have not asked any question, but I have the hardest question here in the room. And I don't know, Nathan, if you know the answer, but maybe if you don't, someone else does. Where do the best baseball players come from? What country? What country? Dominican Republic. Anyway, but you know what? I'll tell you what, Nathan, because some of us are lawyers, we're gonna let you have that one. It's close enough. Thank you. Yes. Now he knows it.
Billy Fox too.
Yeah.
Sudlersville.
That's wonderful. Well, we hope to see you play. And thank you so much for your testimony. I'm going to call on the virtual witnesses now. Thank you so much for indulging us, okay? Oh, yes.
After this, do stop by the office. I have something to show you, Nathan.
Okay. All right.
You'll like it.
Thank you so much, everyone. I'm going to go on now to the virtual witnesses. Who would like to get started? Just unmute yourself. Go ahead. Don't all do it at once. Just unmute yourself.
Hi.
Wonderful.
This is Richard Block. I'm the Executive Director and General Counsel for the Maryland Podiatric Medical Association. And after all that testimony and all that wonderful examples, I'm going to try to be brief, but what we are suggesting, we strongly support this legislation, but we have some amendments that we've submitted that I hope you will consider to provide for more ability to replace the orthotics as opposed to prosthesis, which we deal with in the foot for various reasons, not the least of which is the growth of younger patients who need a replacement. So we would ask that you eliminate prefabricated devices as our amendments, because these are not as effective as specially made orthotics for individuals. And additionally, we would have made other recommendations, one of which is to reduce the time frame from 3 years to 1 year, because there are many reasons why replacement within a year or shortly thereafter are important, not the least of which is youth growth and the like, or congenital conditions that may result in the need for replacement of the orthotic. So on that note, I would strongly urge that this bill be passed with the amendments in order to clarify the coverage. Thank you very much for the opportunity. And again, the testimony was amazing.
At the end, I would like to call Ms. Marlise Gonzalez Fernandez.
Hi.
Hi, how are
Thank
you?
I'm doing well. Thank you for having me, and thank you for having this opportunity to have a hybrid meeting. As you can tell, I had to slip to a patient exam room to be able to be here now as I was seeing patients who fit all these categories. So again, I'm Dr. Marlise Gonzalez Fernandez. I'm a rehabilitation physician. I've been doing this work for more than 20 years. And people who need prosthesis and orthoses are the primary patients that I treat. So I wholeheartedly support this bill. And again, as a physician, I'm deeply involved in the care of individuals who have these needs and have witnessed firsthand the profound impact that access to these essential devices has on a patient's quality of life. You know, I can give you an example of a patient that walked out of this clinic today, very active individual. Larry has a prosthetic device that he uses for work. He works with animals and has to be walking around them and move around unsafe environments that he manages. But although he has the ability to run, he can because the prosthesis does not support doing so. So it would be really important for him and life-changing to be able to, in addition to all the activities he do, include running. And I mentioned to him that I would share his story this afternoon because he is the perfect example of why this bill needs to be passed. I think that one of the challenges we hear is the fiscal responsibility of this bill. And I can say that invariably, improving the patient's quality of life is an important thing to do, but it will also be fiscally responsible. Patients will be having a full life. They'll be moving more. The long-term healthcare costs associated with complications and mobility, diabetes, hypertension, etc., will be reduced. And these devices will help them go back to occupational activities such as working, etc. So again, I urge you to support this bill, and I'm happy to answer any questions.
Thank you, Dr. Gonzalez Fernandez. Mr. Peter Thomas. Good afternoon, Mr. Thomas.
Good afternoon. Thank you so very much. I very much appreciate the opportunity to testify today. My name is Peter Thomas. I'm a Chevy Chase resident since 1997. I'm also a bilateral amputee below the knees since 1974. When I was 10 years old, I was involved in a car accident. I guess I kind of identify with Nate a little bit. I used to be the Nate. It wasn't baseball, but it was snow skiing when I was a child. At 14 years old, I learned how to ski with the help of outriggers and specialty prostheses that protected my knees a little bit more. As an amputee below the knees, I needed to make sure that I didn't damage those knees when I was skiing. Skiing gave me a whole new lease on life. It was the end of a slow motion life for me. Getting the blood pumping and the wind in your hair gave me a certain confidence that I was able to translate into the rest of my life. I began studying more. I eventually went to law school and became an attorney. And I now work in Washington doing, trying to promote the same kind of access to prosthetics that I received as a child. I want to make a couple of key points about this bill. In essence, this bill simply clarifies medical necessity of prosthetics and orthotics. Prosthetics and orthotics is a basic benefit under the Affordable Care Act. We don't believe that the state would need to defray the cost of this the bill because, frankly, this is a current benefit. We feel as strongly that the fiscal note was exaggerated. Most amputees in Maryland are from diabetes and peripheral vascular disease and won't require specialty prostheses. Many will not want or need an activity-specific prosthesis. Very few will require them annually. And the analysis seems to focus on durable medical equipment instead of orthotics prosthetics, which is a very different subset or a different field than DME. We strongly support this legislation. I strongly encourage the committee to vote yes and move it forward to the full body. Thank you so very much for the opportunity to testify.
And thank you, Mr. Thomas, for sharing your story. Miss, tell me if I mispronounce your name, Nina Bandre?
That's perfect. Thank you so much.
Okay, thank you.
Thank
Good
you for your-
afternoon. You can get
Good
started.
afternoon. Thank you. Thank you so much for your time today. My name is Nina Bandre, and I'm a certified prosthetist orthotist like Cheryl, who you heard from earlier. As a provider, I've had the privilege of serving our prosthetic and orthotic patients directly. Allow me to share with you the stories of two 16-year-old patients in parallel. One patient experiences an ACL tear while playing baseball. His surgery, recovery, rehab, and even a knee brace are covered by insurance. After a few months of hard work, this patient is able to get back to playing baseball with his peers. The other patient is diagnosed with osteosarcoma, or bone cancer, that leads to an amputation of his leg above the knee. This patient goes through rehab and is now able to walk independently. However, this patient is unable to acquire prosthesis that would allow him to play baseball again. It is deemed not medically necessary. Without the financial resources to pay for his own prosthetic leg that is suitable for baseball, he no longer plays. His right to lead an active, healthy life is restricted by the current policies in place. His able-bodied peer is able to return to an active life, while the 16-year-old with a prosthesis must sit on the sidelines. In addition, passing this bill to support activity-specific prostheses and orthoses for our patients has long-term cost savings. By staying healthy and active, prosthetic and orthotic users reduce utilization of medical services, stay out of the hospital, develop fewer comorbidities such as hypertension or heart disease. It is also important to note that the more mobile and active a prosthetic or orthotic user is, the more likely and able they are to be employed. One other note is that not every single prosthetic and orthotic user would require an activity-specific device. In many cases, patients will have goals that can be met with their existing devices. By voting for this bill, you are supporting the long-term mental, emotional, and physical health of our prosthetic and orthotic users. I urge you to vote favorably for this bill. Thank you very much for your time.
Thank you for making time to be with us today, all of you. I'm going to open it up for questions now. Are there any questions for this panel? Delegate Hill.
Thank you, Madam Chair, and thank you all very much for your testimony and for the work that you do. And Mr. Thomas, for your sharing your story. So it's been a long time since I've had experience firsthand with amputees and all of that, but explain on average, an adult, how many prosthetic devices might they need to have? A single amputee, say above the knee, lower leg, how many different devices might they need to have in order to be fully functional and participate in activities as this bill would have? And if you could answer that.
Ms. Marlis Gonzalez Fernandez raised her hand. Go ahead, ma'am.
Yes, that is a good question. And honestly, in the civilian world, notwithstanding the VA, I wouldn't be able to tell you how many they could use because there's no availability. So we can justify medical necessity. And again, we, meaning physicians who prescribe these devices, solely based on their need to walk and ambulate in different parts of the community. Now, that said, because of the age and the occupational goals of patients, I doubt that many would have two. And past two, I can't imagine that would be a large proportion, but I don't have data to provide because patients don't get more than one based on their needs.
May?
Let's see, should you? Go ahead.
And following up on that, we also talking about, prosthetics, they change their fit. People put on weight, they lose weight. There's breakdown. Sometimes the stump has to be revised. Sometimes the prosthetic has to be revised. And maybe Ms. Bjorna, maybe you can answer the question. I mean, you're just trying to get a picture that I think sometimes we think it's a device. And I think the intention of the bill is great, but we're about to hear from folks who think it's way too expensive. And if you could just have us have a better understanding of what we're really talking about.
Delegate Hill, Mr. Thomas raised his hand to answer that question.
Thank you so much. I think, first off, I've had 14 different sets of artificial limbs over 50 years, but half of those were before age 20, between age 10 and 20. And so that attests to how quickly children grow, and you grow out of your prostheses. Once you become an adult, it slows down considerably. These are, very durable prostheses that last quite a few years. The longest for me lasted, I think, 14 years. Now that's atypical. Most people need a new set of limbs probably every 3 to 5 years, I'd say. But again, in terms of the activity-specific prostheses and orthoses, custom orthoses we're talking about, I don't really think you'd need more than one or two different sets, depending on the level of activity that you're engaged in. But I want to make it clear that we're not talking about just providing a limb to someone that aspires to be an athlete or compete. That's admirable, and that's something that we want to encourage. We want to encourage people with amputations to go out and be as active and as self-sufficient and engage in the activities that they want to engage in as much as possible. But we're talking about basic fitness. We're talking about health. We're talking about promotion of a healthy lifestyle that enables people with missing limbs or other orthopedic injuries that require custom orthoses to do the kinds of activities that everyone takes for granted, that most health plans should want their enrollees to be doing to decrease their blood pressure and keep their weight under control and keep their cardiovascular health in check, and therefore decrease unnecessary expenses in the long term. It's an important component of this.
You're welcome. Ms. Bondre, do you have a follow-up? I'll ask you a question.
Yes, I have a follow-up on that I'd like to add. In terms of what you're mentioning about weight gain and weight loss, there are a lot of things that we do on the clinician side to accommodate for those daily changes. We educate our patients about how they can use different methods and materials to accommodate for that. And we do our very best to extend the life of every device. One, because that is cost effective in the long term. And then two, in terms of having a well-fitting device for our patients every day. We can't just make a new device each time. We're very cognizant that we are going to make the best use out of each device. So we're making every effort to extend the life of each device the best that we can. And the second is that there is no foot that is simply appropriate for every type of activity. They're simply not built that way. And so different forces and stresses on different materials can lend themselves to device failures. And also if things are used improperly, that can lead to other skin irritation and potentially wounds, infections, and even higher amputations in the worst cases. So I wanted to add that as well.
Any other questions for this panel? Delegate Gazzoni? Go ahead.
This discussion has just sort of led me to think about people who aren't like super athletic, but want to be able to do things, which made me think of older people like, myself. And
come on now.
Well, I'm definitely not a kid anymore. So something like pickleball. If you have a lower leg prosthetic and you want to be playing pickleball and you're like, let's say over 50, would you likely need something that may be more specialized than your regular everyday walking around?
Mr. Thomas.
I would
fit in that category.
I would doubt that I would have a special limb for pickleball. I've played pickleball and I have no problem playing it. I play golf and I have no problem playing that. And it's the same limb that I walk on. It's got, the technology has grown and advanced very significantly. There's a lot of movement and a lot of shock absorption in the current contemporary prostheses that are available on the market today. What I would need a specialty limb for would be a waterproof limb to go swimming, an ankle that would extend straight so that I could use my legs to propel through the water. As I said, a ski limb that would allow me to protect my knees with, say, something called a thigh corset that would help stabilize the knee. You can't have a lot of movement in the ankle with skiing because the ski will go off into the woods when you try to turn. It needs to be static. So it's a specialty prosthesis. Running is a perfect example where you really can't use a walking limb to run. You need a running limb in order to perform that. So there are certain functions and sports or activities or recreation or exercise that you can easily do with a regular walking limb. But there are some that really do require a specialty prosthesis, and that's something that would be covered by this bill. Remember, the other thing covered by this bill is limbs that are appropriate for performance of job-related functions. And that's important because we all want to get people back to work. People who become disabled as a result of a limb loss, want to go back to work. And if they can receive a prosthesis that they can walk around on in their normal daily activities, but also perform job functions with a specialty limb that might be required, it's a whole lot better than public assistance and a lifetime of ultimately sedentary existence that contributes to chronic illness and comorbid conditions.
Any other questions? Seeing none, I want to thank you for just being so knowledgeable and really being patient as we asked all these questions. Your presence really matters, and I want to let you know that, okay? The committee appreciates each and every one of you. This actually now concludes the bill hearing on House Bill 865. Nathan, we'll see you soon, okay? Have a blessed day, everyone. Thank you for your patience. And for the committee, if you